We're going live in 1, 2, 3, 4, 5, and we're live.
Bonda, croeso I gyfarfod bod iechyd prifysgol Cymru Morgannwg, hoddwn yr estyn croes cynnes y bawb sy'n gwylio heddiw. Good morning and welcome to the bi-monthly meeting of the Cymru Morgannwg University Health Board, which is being held in public. We are broadcasting today's meeting of the board live, and I would like to extend a very warm welcome to all those who may be observing our meeting today. A copy of the video of the meeting will be available following our board meeting today on our website for those who wish to view it. I do have a couple of practical points just to go through this morning before we start the main part of our meeting. If I can just ask those presenting reports to take into account that board members will have read the reports in advance of the meeting, and today really is to ask colleagues to highlight the main points in those reports, particularly if anything has changed since they were drafted. I'm going to probably pause the board around 11:30 for a short break. Can I just, for purposes of confirmation, just to point out those who are attending today's board meeting, who are not usually with us. Anna Llewellyn, who's our care group nurse director, Lloyd Griffiths, head of nursing CAMS, and Lisa Davis, assistant director of strategy and transformation mental health. Our colleagues are here with us this morning for the first part of the meeting as part of the listening and learning story relating to the improvement that we've seen in our T-Clidiard service in Bridgend. A very warm welcome to you this morning. Great to see you, and thank you for being able to attend the board meeting. A very warm welcome to Gareth Watts, our new Director of Corporate Governance and Board Secretary, who is attending his first meeting of the board today. Also, a warm welcome to Mark Thomas, our Deputy Director of Finance, who is attending on behalf of Sally May, who sends her apologies. Also to Richard Hughes, our Deputy Director of Nursing, who's here to observe the proceedings of the board. Can I also welcome Sally Davis, our Deputy Medical Director, who is here on behalf of the Medical Director, Don Burford, who has sent his apologies. I have some colleagues joining virtually, Ian Wells, one of our independent members, Sarah Utley and Paul Dalton also joining us virtually, and I think perhaps Darren Griffiths and Vanessa Davis may well be joining us a little later. We've received apologies from Linda Thomas, Anne Morris, and as I said earlier, Sally May and Don Herford. Item 1.3, declarations of interest. I've not been told of anything that is pertinent to today's agenda, but if anybody has anything they wish to declare, I would ask that you do it at this point. Nope. Okay, tremendous. Item 2, just to quickly touch on the consent agenda business, just so that we're focusing our attention today on the critical activity and discussions. I want to make sure that we use the consent agenda for this meeting, and colleagues have had the opportunity of reading those things which are for a matter of consent. And as usual, if there is anything that's towards the back end of the meeting that you want to brought forward into a substantive item, can you let me know now? And if not, then I'm proposing that we will ratify those matters as we get to them fairly quickly. No? Okay. And thank you very much. Item 3, our shared listening and learning section. I'm really pleased to invite Anna, Lloyd and Lisa to present today's listening and learning story. I know that many of us will have been following and participating and engaging in the tremendous journey that we have seen within our T-Clidiard service in Bridgend, and we all appreciate the enormity of the work, the collective team effort, the leadership, the creativity that we put into improving the service we have there. And I know for those of us who've had the opportunity to visit, we've really seen the outcome and the output of all of that work. So now I'm going to ask Anna and the team to present the story. Just to say, I think there's going to be a presentation. So for those viewing on the live stream, you won't be able to see it whilst the presentation is being shared, but I know we'll be able to put that on our website at some point as well. So Anna, thank you very much. Over to you.
Thank you. Thank you. Good morning. Thank you, Chair. It's an absolute joy to be here today to talk about the improvement at T-Clidiard. So The picture that you see on your screen there is Teesside Yard. It's a 15-bedded unit that serves the whole of South Wales. It's commissioned by WISP to provide inpatient care for young people with mental health needs that can't be met in the community. There are 2 such units in Wales, Teesside Yard in South Wales and a North Wales unit. So that's the only provision in Wales. If we go to the next slide, please. So today, colleagues are going to talk you through the improvement journey. It's outlined there in the slides, what we're going to talk about. If we go to the next slide, please. So just a bit of background for board members. Back in 2018, long before many of us were around, Teesside Yard was placed in escalation by WISC, a fairly low level of escalation, following a very serious incident where a young person called Manon Jones died at Teesside Yard. And it's unusual for us to use the names of patients, but Manon's family are really keen that that she is remembered. So Manon died at Teesside Yard, and there began a programme of improvement way back in 2018. And the service at that time had been working with WISC around an improvement plan and had made some progress, particularly around really quite transactional items. Then in 2020, CTM, as many of you will recall, reorganised, and we had what were called integrated locality groups at that time. And I became the nurse director in April 2020. And by November 2020, we were really getting a sense that we had significant concerns around CAMS in its entirety, not just Teesside Yard. Concerns around performance in some areas, culture in other areas, and in Teesside Yard in particular, concerns around the management of quality and safety. So we took a paper to what was then called the Management Board and sought some support for some interim additional support, leadership support, to go into CAMS to further drive the improvement. And we were fortunate that the executive team at that time supported that additional support. Very quickly, that additional support identified that there were some cultural issues emerging also at Teesside Yard. Some of them long-standing, some of them exacerbated by the pandemic, and the pandemic, many people talk about the impacts on acute services, but Teesside Yard experienced significant demand, unusual demand that they hadn't seen before, in terms of young people with eating disorders and also emotional dysregulation. So they had a particularly challenging period on top of the long-standing difficulties that they had. And then in November 2021, there was a HIW inspection and further reviews by external bodies. So Teesside Yard was a place that was subject from 2018 to a high level of inspection. It's probably the most over-regulated, reviewed place by multiple bodies. And it was a team that were very much in the spotlight and feeling quite fearful. So as an integrated locality group, we really felt that it was important that it had its own dedicated leadership team that were to drive nurturing improvement, nurturing the team there, rather than having an assurance-focused leadership. And I'm really pleased to tell you that Lloyd and Lisa took on that role as leaders of the Teesside Yard improvement, and I'm going to hand over to them now. They're going to stand. Sorry.
Because we're a bit short. Yes. So if you go to the next slide, please, Carl. So as Anna's described, Teesside Yard had lots and lots of different action plans and different reviews and different recommendations. And I guess what we came across when we kind of came into post is that those were quite transactional, very tick box. And as Anna's described, the colleagues in the unit very much feared kind of what those action plans asked them to do. So our first approach of the improvement programme was to kind of pull together all of the different reviews and recommendations to form more of an integrated action plan. But I guess what our main focus with that was to think about what our vision was. What did we actually want to see Lydiard to become? So not to stick to kind of transactional actions. And from that, we wanted to be really clear about what our objectives were. So making those very clear around the outcomes rather than the actions as well. So on your screen, you've got an overview of a driver diagram, kind of the work streams that we established and the kind of clear objectives that we kind of pulled together. Our improvement process was overseen by Lauren, so we had an improvement board and we reported against all of the different actions into the improvement board with clear metrics to show outcomes and experience, just so that we could keep track of that on a kind of a monthly basis. We'll move on to the next slide, please. Thank you. We've got some handouts today. We're not going to give them out just yet, but we'll give them to you at the end. But I guess as part of our reflection of our improvement journey, we really wanted to kind of think about where we've come from. And this is a really good, I guess, example of all the different steps that we've taken on our kind of improvement journey to date, and lots of the detail of all the little things that we needed to do in order to kind of achieve what we've achieved over the last couple of years. Go on to the next slide, please. So instead of talking to you today about our 50 actions within our integrated action plan and all the evidence, what we wanted to do was actually think about why our improvement journey has been successful and what the kind of key recipes or what the ingredients are for the recipe for improvement. So we're going to take you through now a couple of slides in terms of some of the key things that we think are really important from a reflection perspective. Move on to the next slide, please. So at the heart of our improvement has been engagement. Myself and Lloyd have got a compassionate leadership style, and we really try to embrace kind of collective leadership within Lydiard. So from the very beginning, we really wanted to understand and listen to our colleagues and our patients and their families about what really mattered to them, and to form our improvement journey from that evidence and that information. In the very beginning, we embraced being open and transparent. So we invited people in, and we asked for people to feedback in terms of what they were seeing in Lydiard and what we needed to improve. And I guess alongside that, we've also introduced, or we did introduce, a weekly improvement meeting that was open to everybody to participate in. Everybody's views were welcomed and valid. And from that work, we effectively could build our improvement programme. A good example of this is that when we were trying to improve our clinical records and identified information within the clinical records, our ward clerk suggested that we should colour the one part of our section in a different colour paper in order for that to be easily identifiable, simple and effective, and really important for kind of some of the improvement that we've done in our clinical records. Alongside this, obviously our patient involvement has been really important, and we've also introduced kind of weekly meetings with our young people to get their feedback. They've informed all of our activity programmes and works and given us lots of feedbacks of things that we could put in place in Lydiard to make their experience better. And Lloyd has been developing kind of the patient experience group and developing our lived experience strategy so that we can bring back people that have been to the unit previously and be part of some of the improvement work to date. Go on to the next slide, please. I think it's really important to recognise that we have had investment in Lydiard. We were really fortunate to have a sum of money from WISC to invest in our therapies workforce. That was kind of a big gap within our workforce infrastructure. And we've been able to create new posts and bring in different ways of working into Lydiard as a result of that investment. We've also been really fortunate to have additional capital works within the unit. It's quite a modern unit, but there was areas that we needed to improve. And on the screen, you can see the picture of where we've moved some of the ward layout so that it's more effective for our colleagues and patients to be kind of connected on a day-to-day basis. I think it's also important to recognise that corporate teams within CTM have supported us in our improvement journey. So we've had input from Workforce and OD in terms of our culture and leadership programme and supporting our clinical leads within the teams. We've also had input from the improvement team within CTM to develop our quality improvement approach. And I think it's also important just to recognise that we've tried to be prudent and creative with our own budget. So we've looked at our skill mix, we've changed kind of the rosters, and we've also looked at using our charitable funds to fund initiatives within the units and use kind of initiatives like music in hospitals to bring different activities into kind of Tillage Yard. I'm going to hand over to Lauren now.
Okay. Next slide, please. So by now you've seen the logo and used by the 4 Cs. So this is the story of how we came about. So I went to Tillage in 2001, and it was pretty soon afterwards that Anna was asking me, how are we going to improve? What's your priorities? We came up with a framework that we called the 4 Cs. Care and compassion should be underpin everything that we've done. And to be fair, that they were always in Tillage, probably lost their way a little bit. In terms of scrutiny, that Lisa's talked about, Tillage is probably the most scrutinised, both internally and externally, unit that I've ever been involved in. There are numerous action plans, numerous recommendations, and a lot of short-term reactive solutions to what were longer-term problems. And this has caused a lot of anxiety and disillusion amongst the staffing group. So it's fairly obvious that we needed a calm approach from the start. And the 4th C is confident, and this is what's underpinned pretty much everything we've done along on our improvement journey. We wanted our young people and their families to have confidence in us. We wanted our staff to have confidence in themselves, in each other, and us as a leadership group. And ultimately, we wanted the Health Board, Welsh Government and the general public to be more confident in us. So we started to work this into a philosophy, and we felt it dovetailed nicely with the Health Board values. So it was during a conversation with some of our commissioning colleagues, someone made a very throwaway comment that if Tillage was a private provider, given its reputation, it would change its name and its branding. For us, that was a bit crass. We had to respect the history and use that to drive us for improvement, but we liked the idea of creating an identity. We worked with a company called Scarlet Design to turn the 4 Cs into both a philosophy and a logo. And it was really important for us that this was co-produced for young people. An example of this is the early versions of this were a house. Tillage was a house. The 4 Cs started off in the rooms, then they were underpinning themselves in the foundations. And then one of the young people said, it's not my house, I don't live there, I live in Newport. We had to go back to scratch and start again. So eventually we held a stakeholder event that was attended by past and present service users and the carers, all our stakeholders and our current staffing group. And we presented some ideas and asked for feedback on what the thought of the 4 Cs and what they meant to them. And we also presented a number of options for our logo. Pleased to say that the one in the centre of the slide was approved by 70% of the people who attended. So this is now our current logo, and it's branded pretty much everywhere in Tillage. So Tillage is represented by the tree. The birds are the young people, and they fly into the tree when they need some sanctuary. They fly off at times, they decide if they come back. Inclusivity is really important to our young people, and the leaves of the tree are rainbow colours to represent that inclusivity. What's different to this logo for the others that we developed is the roots. The roots are what makes Tillage strong and able to grow, and they are representative of our staff, our families, and the wider Health Board, you guys, the people who support and enable Tillage to grow. So if you come to Tillage now, you will see this logo and various others branded across the unit. The young people have actually turned the tree now into more of a woodland scene, and there's loads of animals in that, and some of them are representative of the young people's own pets, and some of our therapy animals are therapy dogs and our alpacas as well. So next slide, please. But we want to put the young people at the heart of everything we did on our improvement journey, and we felt that if we did that and were true to that, then the improvements recommended by people like Whiskey HIW would automatically follow. To do this, we wanted to empower our staff to drive their own improvements. So with the help of the ICTM team, we facilitated quality improvement training for all of our staff and set up a quality improvement forum where people of all grades could come and float ideas to test things out and to discuss quality improvement. To do this, we had to model the 4 Cs. We had to be confident in our staff to come up with their own ideas for improvement. We had to be calm enough to give them the time and the space to fully develop their ideas. It was very clear from the start that our improvements needed to be tangible, but this probably dominated my life for the last 2 years. But we had to make sure that our improvements were as measurable and evidence-based as possible using some of these outcome measures on the screen. Go to the next slide. This slide is an example of how we use measurable data to put the improve into improvement and make the improvements we made almost undeniable. This slide shows the results of a 6-month quality improvement program that covers several areas of a HIW review. This project is now being digitalised and uploaded to our mat, and it's now part of our monthly water assurance program. Next slide, please. Throughout our improvement journey, we've kept the so what at the forefront of our thinking. We didn't want another sticky plaster solution, which is quite ironic given the amount of stick on graphics that we've used. This slide and some of the other data, including the packs and the leaflet, show the impact of the changes we've made. There's no doubt the change in the culture, empowering staff and engaging more with our young people, made T-Lydia to become a safer place to both be cared for in and to work in. This slide shows the reduction in restrictive practices, largely through from using NG feeding for most people with an eating disorder. That was a huge part of our escalation status on our improvement journey. We're incredibly proud to tell you that 2 of our healthcare support workers, Christian and Kirsten, have been shortlisted for a national RCN award for their work in this area. We look for a positive result in November. Next slide, please. One of the key changes we made is to collaborate and co-produce more with our young people. They're now truly at the centre of everything that we do. And this is the slide that shows some of the feedback we get from them. In the leaflets and some of the other slides, you'll see a large amount of evidence of some of the improvements we made solely on suggestions of young people and their carers. The mantra of not about me without me is now truly embedded. Next slide, please. One of the issues that drove the need to improve was the leadership and culture of T-Lydia, characterised by high levels of sickness, vacancies, turnover and other work-related issues, which you can see in some of your packs. A large part of what we were at the start of our improvement journey was to listen to and engage with our staff, and we used a visible leadership approach. We implemented drop-in sessions and wait days, which were really well received. The quality improvement work has empowered the staff, and the logo on the uniforms of our buildings have instilled a sense of pride and identity, something that was sadly lacking in the past. This slide shows some of the feedback from our colleagues in T-Lydia, and we're now really proud to have a harmonised, truly multidisciplinary group. They're really proud of the care that they deliver and the environment they work in. Next one, please. Prior to our improvement journey, T-Lydia was a very isolated and introspective unit. It was clear from the outset that we needed to have the confidence to be more transparent and show people the work that we've done. We facilitated many visits to T-Lydia from the Children's Commissioner, the Deputy Minister, and many of yourselves, and that's all about trying to instill more confidence in the unit. This slide shows some of the feedback that we've received. The next one, please. This slide shows the results of our improvement journey. We're really proud to be stood here today representing the unit that's now been fully de-escalated by WISC. We're also really proud that in the last couple of weeks we've had an unannounced HIW visit that early feedback looks to be really positive, and we're now in a position where we're looking forward to receiving an HIW report on Chris. I think that's the end for us, and I'm happy to take any questions.
Thank you both. And before I throw it to questions, can I just say, to see the turnaround in what is a relatively short period of time is just simply remarkable. That comes down to that commitment, that passion, that focus, the leadership that has been driving that change. And I it's terrific to see the outcome that you succeeded in achieving. Lauren, was there anything else you wanted to add? I know you've been at the forefront of this.
Yeah, just to say how incredibly proud I am. I feel quite emotional actually. The journey that you guys have been on, and that comes across so well in the slides, and the impact, I think, for our workforce, for our patients, for the families. So yeah, incredibly grateful for the leadership role you've taken in this.
Cool.
Yeah, I mean, again, I remember not long after I started actually the job, I came to teach at the art, and it's one of those examples of a place where Anna will know what I thought at the time. So you were there with me, weren't you, Anna? And we left, and I think we seemed to remember having a conversation in the car park, and like thinking, something just doesn't feel right here. And you know what? It's that thing about when you can go into a facility and there's just something you can, there's nothing concrete you can lay your finger on, but it's just a general thing. And to see now where you've come from is just incredible. And also, you shouldn't underestimate the scrutiny that these guys have been under. I mean, right up to the minister. I mean, the number of emails I've had over the past 3 years from the minister's office, the deputy minister's office, the level of scrutiny and oversight that these guys have had whilst they've been doing all of this work. Not only is it really a massive task to do this work, but when you're doing it with everybody outside looking in and giving an opinion, or and I know you've often felt you've gone forward 5 steps, and someone else comes in and you feel like you've gone back 3 steps. But to see where you've got to now, and what I'm just sitting here thinking is the whole way you've done this and the approach you've taken, that combination of data-driven quality improvement, patient involvement, family involvement, staff involvement, is a real example of how, when you do these things in that comprehensive way, the outcomes are so significant and so tangible. And there's something there for us as an organisation about taking the learning of the way you've done this programme of work and how we apply it into other areas where we work in. I know, Anna, you're doing similar work in other areas of mental health. There's a huge amount of learning for us as an organisation about how to do these things really well, that not just tick a box, as Lloyd said at the beginning, of just responding to a report that's come in and we just change something because someone's told us to, but how you actually embed this really fundamentally in the way the organisation runs, the way the unit runs. And I just think, well done to all of you, and that, thank you to everybody for all the efforts and hard work, because I know it's been really, really hard work as well. You can't get away from the fact that the effort and energy that you guys have personally put in to make this a reality. So you should be really, really proud of it. And we are all really proud, as Lauren said, of the achievements. So thank you.
And then I'll bring Carol. Yeah.
Yeah, just to come back on that in terms of the learning for other improvement, I think it's really important to say that CTM did have some additional investment.
Yeah.
It was previously a clinical service group that was embedded in children. So Lloyd and Lisa were new posts, and it required that dedicated focus. And also in terms of future improvements, time is important. We need some patience. The improvement definitely accelerated clearly when Lloyd and Lisa started, but they had been on an improvement journey since 2018. So it's just important to bear that in mind when we're thinking about future improvements. It does require some patience.
Yeah.
Carol.
Thank you. Well, part of the scrutiny has been that CTM have been reporting to every quality and safety meeting while this has all been being undertaken, and it's been hugely heartening to see that ongoing improvement and progress, and to see just the level of improvement is fantastic. So congratulations. One of my points was about the shared learning, so that's been covered. The other is about how we sustain this, because often we do see that there's a big focus on an area. Lots, resource goes in, we improve. How do we make sure now that this is sustained?
Yeah.
Well, probably something I missed in my part of the presentation is that a key part of our improvement journey was empowering our kind of clinical leads within the unit. So that weekly improvement meeting wasn't led by me and Lloyd, it was led by our kind of senior nurses and a social worker within it. I think the HIW experience a couple of weeks ago was a good testament to showing that it is sustained, because Lloyd wasn't here. So we got through it really well, with the kind of the senior nurses taking charge, being really proactive, and that was some of the feedback we got from HIW, was that there was excitement in the year for HIW. People wanted to go and speak to HIW about their experience of working. So I feel as though some of the systems that we've put in place in Lydiard is around empowering everybody to be part of the solution, and that real focus around teams in Lydiard and not about individual leaders.
Yeah, that's hugely important, isn't it? That's really good to see. Thank you.
Yes, no.
Yeah, first of all, can I say a huge thank you for the work you've all done and the results there. And often we have presentations like this, and I see presentations with other organisations I work for, and there's a huge energy in getting it sorted, running at the problem and trying to deal with it. But can I just say, and I made a note of it, and I've done problem solving for years with the police, etc., and you've taken the process exactly right. And it's something we need to pass on to others. You've done the scanning, but you knew there was an issue. You did the analysis, and then you responded, but you've done that, and you're still doing the assessment and the evaluation now. And that is textbook way how to deal with problems, because what happens then you can get sustainability.
Yeah.
Because once you know what the issue was and how you dealt with it, you can replicate it. And I thank you for the honesty, because that phrase, you lost your way. And I'm sure there are other departments that might, as it's the nature of things, lose their way. And I think what you've done is going to be helpful to our organisation to make sure perhaps you can step in and act as mentors and advisors to other departments and other areas who are facing similar problems. But and again, I just want to say a big thank you, because you've done it right.
Yes, so I echo everything that's been said. Thank you very much. It was also reported to the Mental Health Monitoring Committee as well. So it's had a good airing, and congratulations on this massive turnaround. I wanted to ask about sustainability, as well as now that you've done all this change management, how do you keep it going? But that's been answered. So I'll ask instead, where are we then in terms of these myriad of Mary Poppinses who are keeping an eye on you at the moment? Are they starting to float off within umbrellas? Are they going, where are we in terms of the recommendations and that sort of area? Are they fluttering away happy now? And are we de-escalating essentially?
Well, the short answer to that is yes.
Yeah.
We have fully de-escalated from WIC and HIW. We're expecting a positive report, and we're anticipating that will mean that we'll fall back into a usual cycle of inspection. So yes, is the short answer.
Linda.
You touched on this a little bit, but I wonder if you could just reflect a bit more on what we as a health board did that was helpful and what might we have done that wasn't helpful, so that we can also learn to take that to other areas.
I think I better answer that. I think the things that were helpful were agreeing some additional investment at the beginning when we went with we have got a real problem and we need some dedicated leadership support, and that trusting the report that we presented, and so that was really helpful. All of the corporate departments, and I include estates, workforce and OT, ICTM, in fact everybody that we asked for help came to our aid. I think perhaps in the very beginning, that over scrutiny that we talked about in terms of external stakeholders at the beginning, because when organisations are worried, there can also be a tendency to over scrutiny. So you're a bit like rabbit in the headlights. So I think for you as a board, I think some of that allowing time and space whilst you're all sitting with your worry a bit, I think.
It's something about holding our nerve, I think, and
Yes.
Allowing the pace and the things to take their time, and then giving you guys the permission to push back when you felt something was being more reactive. So I think taking that on board.
And also say, we were trying to fend off also corporately quite a lot of the noise. I was getting the minister's office on the phone and and emailing, and you see it's we are and it's that. Your point about patience is also explained to them that this is a process of to be patient and bringing that. And I think what Lloyd and Lisa did really well also was not shy away from that, but actually be proactively inviting the minister and the deputy minister to come in, inviting the children's, so actually saying it is a work in progress. There's still more to do, but come in and see, because you'll have seen that it's improved on 6 months ago from when you were last here. And I think that was a really positive tactic. It showed, what I saw with you guys was you moved from the unit moved from being much one of where perhaps there was a bit of defensiveness about trying to keep people away from saying, we know it's not all perfect yet, we know there's still work to do, but come in and see what's happening, come and be part of the conversation, come and help shape that. And I think that also builds that confidence of people think, well, if you're that open, then actually you've got nothing to hide. It's not like you're being kept away because you're worried we're going to see something you don't want to see. And I think that's also culturally quite a big mindset shift to make.
Any other comments or questions?
Quick comment. Brilliant presentation. It's really brilliant to see all the sort of positive work that's happened over the last couple of years, really. But just to say, sort of comment wise, that the safeguarding board has also been very interested in the journey of TVDR. So it's been a standing agenda item for a significant amount of time now. We had a safeguarding board last week, and they've stepped it off the agenda. They're no longer sort of going to put it on their radar. So it'll be really good to see sort of the updated sort of inspection report and take those forward. So well done, everyone.
Again, thank you for coming to the board this morning. Absolutely phenomenal way to start our board meeting, hearing about progress, improvement, and just the immense way in which you dealt with the challenge. And Paul's right that sometimes people think that challenges and problems can be resolved very, very quickly, but you do need that patience and that fortitude and that belief that the direction of travel is the right one. And you had that in bucket loads, quite frankly, and amazing. So thank you very much indeed for coming, and well done. Brilliant. Thank you.
That's it, we can move up a little bit.
Okay, moving on to item 4.1, the chair's report and the effects of common seal. There is a report from me for noting. Just one observation, I suppose, and building on the conversation about T Lydiard. Last week we had the official opening of the Snowdrop breast cancer unit here in Llantrisant, and one observation, I suppose, and I made it at the opening, and that is, when we look at health service transformation, people always think we're talking about what we do on our large hospital sites. But here's a fantastic example of where, using a relatively small building, the health board and all of those colleagues who have led this project have developed and delivered a transformational service in what is a relatively small office block, but giving patients who are facing diagnosis and treatment and discussions with consultants a much pleasant environment in which to go through that process. And it was amazing to be there last week for the opening. And again, it just reminds us that sometimes transformation isn't the big stuff on the big scale. It can be quite relatively small by way of its construction. But my goodness, the impact for those patients, 3,000 of whom have been through the Snowdrop Centre since February, does give people a very different experience as a patient. So again, I think just to record my thanks as chair to all of those who not just contributed to last week's opening of the centre, but those who have delivered and developed and continue to engage in the development of the work, particularly Sally and colleagues. Just phenomenal, absolutely phenomenal. And to hear the patient experience being brought to life last week really was something. But it just shows us what can be done at a different scale, and I think it's always worth keeping that in mind. Just to alert colleagues to using the common seal, which I will ask you to endorse in a moment. Just to flag up the chair's urgent action that I did take around the commercial negotiations, and can I thank colleagues for approving that urgent action in advance of this meeting. So just to ask, before I ask colleagues to note the report and the actions taken, are there any questions or comments on my report? No? Okay. In which case, I can just ask colleagues to endorse the affixing of the common seal and also to endorse the chair's urgent action that I took. Yes, thank you very much. Much appreciated. Item 4.1.1, the action log. Again, it's just there for noting. I don't know if there's any updates on the action log as tables. No? Okay, in which case I just ask colleagues to note the action log unless there is any question that colleagues have raised. Oh, okay, fantastic. Thank you very much indeed. Item 4.2, the Chief Exec's report. Paul.
Thank you, Chair. So a couple of things to draw out from the report. First of all, about the escalation status. As you'll know, there's been a review of escalation status back in July from a tripartite perspective, and the current status of the health board is listed there. So you'll note that in both maternity and neonatal and quality governance, we've moved down from targeted intervention to enhanced monitoring and remain in enhanced monitoring for planning and finance and all the TI performance. I think obviously this is a real positive step forward for the organisation, particularly obviously around our maternity and neonatal work and the quality governance work. It evidences again the improvements that have been made in those areas. We actually had a conversation on Monday this week, with Welsh Government as well about the next phase of the escalation. So what were the outstanding areas of work that they felt needed to be in place to look at a further de-escalation for both maternity and quality governance. So that was a helpful conversation, a couple of areas that have been highlighted there, which I think we're pretty confident we can deliver in the next couple of months. The next tripartite meeting, I think, is planned for the 18th of December. So the conversation was whether we would hope to be in a position that we will have achieved the outstanding areas of work by then to see further de-escalation in maternity and quality governance. On performance, there are a number of trajectories that we've got agreed with Welsh Government which are on track. And we would be confident that we'll with the trajectory as it continues, that we would see further improvement in those as per our plans. So we'd hope that that would be also in a position to be reviewed. And then on planning and finance, every health board in Wales has been placed in enhanced monitoring for planning and finance, given the financial challenges that all organisations are facing at the moment in Wales. So that remains in an enhanced monitoring status. So, you know, really positive to see the improved state of escalation, but obviously further ambition to progress further in the coming months on that. There's an update there about the Adjacent Health Park, as the chair mentioned. We've now concluded the commercial negotiations with BA on the exit from the lease, and as of 1 minute past midnight tomorrow, we have full occupancy of the site. BA will have exited the lease at that point, so we are able to get onto the site then when we need to. We had a programme board yesterday for the programme, and there's a lot of work going on now behind the scenes on the technical feasibility, the surveying, all the sort of stuff that needs to happen to give us the master planning sort of plan around how the site will be developed. And in parallel with that, there's also the clinical conversations going on within the orthopaedics, the diagnostic specialties. If and I had a conversation yesterday with HEIW about the educational opportunities that may be on that site as well. So it feels like we're starting to get the programme starting to gather pace, and we're starting to resource the programme now with capacity to make sure that that is delivered. Those of you who don't know, we appointed Rosie as the programme director for the LHP site, who's currently our head of capital. Got a lot of experience, obviously, in capital programmes of work, has a background in both legal and accountancy as well, so has a range of experience that is really going to be helpful for this programme moving forward. So it's really positive to see. And the other thing to say on that topic is we also arranged a visit last Friday for a number of the local MSs and MPs to come and visit the site, partly just to sort of, a number of them had expressed an interest in understanding what was going on there. So we took them round, and I think it was really positive because they could see the scale and scope of opportunity that the site presented, and were really keen to know what they could do as elected members to help support that programme of work, and could see a real opportunity here to create a landmark facility in South East Wales. So really positive involvement there on that topic. Just also to update on the national commissioning arrangements. I think we've mentioned before here that the Minister earlier this year asked for a review, which was undertaken, of the current arrangements of commissioning for both specialist services through WISC and the Emergency Ambulance Service and NCCU. A report was put together earlier this year which concluded that there would be a benefit of bringing together all of those functions into one place and having a national commissioning vehicle committee that was acting on behalf of all of the organisations in health boards to deliver a range of commissioning that would make sense to do at a national level rather than a health board level. There's a programme of work now being established to do that, and I am on the oversight board because obviously we host all of the current arrangements, and the plan is that the new entity that's created in April will also be hosted by CTM. So we need to make sure that we are part of that, and there's also another chief exec rep on that group. Gareth is now also getting involved as this sort of director of governance on that programme of work. I think it's fair to say there is still some work to do. It's quite an ambitious timescale set out to get this all delivered by the 1st of April, and there's quite a lot of work to do to get us there. And I also think it's really worth reminding ourselves that these groups, these existing committees, are committees of the health boards. So they effectively discharge some elements of our responsibility through those committees. So it's really important that we, not just we as CTM as the host, but we as a commissioner of services are really involved in that process. And we were having a conversation with chief execs earlier this week in the other health boards about making sure that whatever the model is for the future, that it is really designed to make sure that the health boards understand how that governance and accountability can be discharged to this new committee, because I think we have a responsibility for the total health needs of our population, of which some is specialist. So it's really important that that is built in, and also particularly from a planning perspective, that we know from a commissioning perspective, what the specialist services are planning to do, so that, because we are ultimately, it's our money that is being spent on our behalf, so it's really important that we are part of that. So I think having Gareth involved and make sure that those governance lines are really clear and accountable are really important. And also as the host organisation, we need to be really clear about where responsibility begins and ends, just sort of day-to-day management. So that there's work ongoing. I know chairs are also starting to have some conversations about that as well. So further updates will be shared obviously as that develops. So those are the key results.
Thank you, Paul. Any questions to Paul on the report? Okay, thank you. If I ask colleagues just to note the Chief Executive report. Thank you very much. Item 5, delivering our plan. We'll turn first to the integrated performance dashboard under 5.1, and I'll ask Linda to go through the introduction and the overview to the dashboard. Thank you, Linda.
Thank you, Chair. So my first task is to sort of present the presentation at the top of the report, and remember that we've been working towards making some changes since we had a workshop back in April to sort of work through how we bring to you what you need to see and what we have to do in terms of the 100 odd metrics, whilst elevating some to bring to your attention some of the sort of more high level, more important, sort of indicative measures that give you a bit of an overview of the sort of health of the organisation and its delivery. And so what we've got here is how far we've got with that. And so, and of course, as is the way of these things, we've put more in. Although we've really worked to make sure that, so we've done that, essentially we're looking at that first page, which is 44 of the whole 1,000-page pack. Where as execs, each exec has worked to, we asked for sort of a dozen or so high level metrics to really flag what's going on, and we've got it to 16. But I think the presentation of it obviously still remains pretty crude, and we've got, you know, we've chosen those 16 because we think those are the right indicators. They're not new indicators, they are a repeat of indicators that are in the pack already. So, you know, we're not introducing measures, we're just elevating the presentation of some of these. There's a very crude arrow system about whether things are improving. I mean, clearly some of you can see the figures there. Clearly some of those are sort of natural variation rather than, and so I think we need to improve again some of the way that we're presenting that. But I know that so Stuart and I done some work to try and, you know, move this on. I think in many ways, you know, we're sort of conscious of some limitations in terms of the sort of resources that we have. I don't know if you want to.
No, I think you've articulated that well. So from my perspective, you know, it is still very much a work in progress in terms of the visual presentation, and you know, you will see a difference next time. It's just one of those things where we've worked with the team over the last couple of months to just get us to this point. So
so I don't know if you want to pause to just reflect on that bit or go straight into each director then talking about their content.
And I accept that, you know, with the volume of work, with the number of metrics, measurements that we're trying to report on and trying to analyse, that this does take time. Any colleagues want to raise any points or questions in terms of where we are, how we're getting there? Trying to streamline this is really quite a bit.
Yes.
Get it? No. Okay. Anything else, Linda, or are you happy for me to?
No, I think on that, I mean, do feel free to talk to us outside, because you know, we are also looking at, you know, different ways of, you know, doing it all. So it's not that this is the, we want to make it clear that this wasn't our final offering. But let's, if there's anybody got any comments on that, very happy. Otherwise, let's move on to the director's reports. Thank you.
Okay, thanks. Get on the operational performance side of things. Anything to say on performance improvements? I know, you know, because we have been singled out by the health minister for the improvements in reducing. So Gold Star. The Gold Star was awarded by the health minister at the NHS Compared Conference for our improvements in reducing the long waits. So congratulations to getting the team for that. However, it does set us up on a particular plinth. We have to be very careful of not being knocked off it. Getting some anything on the performance side.
I'll just draw out a couple of key things. So firstly on urgent care, whilst it's been the summer, it has remained an exceptionally challenging position on urgent care. Our attendances remain elevated, both in terms of self-presentation and ambulance conveyance. As you know, within our targeted intervention, one of the key areas of focus has been to reduce the number of long waiting ambulances on our forecourts. I'm pleased to say that for Q2, we will deliver the agreed reduction. So that will be 2 quarters now where we have managed to reduce the number of 4 hours. Just in terms of minutes lost in August, we on average, each ambulance lost 52 minutes. The range in Wales was between 23 minutes lost, and that was in Cardiff, and the Health Board with the longest delays was seeing on average 137 minutes of delay per ambulance. So we are the second lowest. Clearly we want to bring those numbers down, but the number of the lost minutes per ambulance on our forecourt is the second lowest now in Wales, and that remains the situation until Monday just gone for September. So again, we're sustaining. We're not where we need to be. There are other improvements we need to make, but we now have the 4-hour policy in place now across all our 3 emergency departments. It went live at the beginning of September at Prince Charles, and is being worked through. The next real focus for us is around the functioning within the emergency departments with that 4-hour to discharge or admission, we've had internal audit looking at that for us. We're expecting that report imminently, which I believe will identify that we haven't got a consistent process for reporting, so we can then work on the implementation of the actions from that. I know after the last board, I wrote on behalf of the board to Stephen Harry, the Emergency Ambulance Commissioner, to raise the concerns of the board that whilst we were reducing the number of delays, we weren't seeing a corresponding improvement in RED performance. We've had a holding response from Stephen, and he's due to come to October's board to present on and will be answering that at the board with a presentation from the data mining that he's currently underway with. In terms of planned care, as the chair's mentioned, we have seen a continued positive improvement in our longest waiters, and we remain on track to deliver within the ministerial ambition by the end of March of 99% of patients being treated within 104 weeks. We've got some very focused work on some of our very long waiters, which offer some very specialist procedures in urology and ENT, and we're just finalising treatment plans for those patients. The other area, and we've had a deep dive on this at both PPF and Quality and Safety, has been about ophthalmology, and just to update the board, recognising the risk of the volume of patients, both in terms of waiting for first appointments, but also follow-up, particularly those with glaucoma. There are a number of actions. So we've had GIRF, the Get It Right First Time team, which is a national review team from NHS England, who are now working with NHS Wales. They've identified a number of improvements that we can make, which we've already started to enact. So as of now, the whole glaucoma service is managed via Princess of Wales site. So we've got a single process and a single way of delivering glaucoma. We've appointed 2 additional ophthalmologists to deliver the additional glaucoma capacity, and we've just put out an expression of interest for some additional outsourcing capacity for glaucoma, and both predominantly for our follow-up cohort. And you'll note that ophthalmology is our biggest specialty with follow-up's not booked. The other area then on cancer, so cancer continues to improve a little. So we've certainly stabilised the cancer performance, which was quite volatile. The key areas of issue for us is endoscopy capacity. We are just literally within the next week going to be awarding a tender for additional insourcing capacity, which will include bowel screening Wales. One of our challenges is the volume of screening endoscopies that we've got and the accredited capacity we've got to deliver that aren't in equilibrium. And so part of this is help to address that. The other thing, just to bring to board's attention, is a matter that we've escalated with colleagues at Swansea Bay, is around gynecology cancer performance. So at the moment we have patients from the Bridgend catchment to manage through a Swansea Bay delivered service, and patients in Merthyr for the Merthyr and Llantrisant sites are managed through a CTM service. A lot of work with the opening of the Women's Hub has seen the average wait now for an urgent referral and for postmenopausal bleeding now down to sub 20 days. And we're working to a maximum tolerance of 20 days there for our faster diagnostics. Unfortunately for patients from the Bridgend catchment, that waiting time for first assessment in the service at Leith Talbot is well in excess of 60 days. So we're working with Swansea to understand what actions they are taking to address it. We have moved patients from that waiting list to the Royal Glamorgan for scanning for the first part of that assessment, because if on the results of the ultrasound will determine whether or not you need a hysteroscopy. And so we're continuing to work with Swansea, but 75% of all the patients now waiting over 62 days in gynecology are patients in the Swansea Bay service, both for diagnostics but also for surgery. So there are long delays as well for the big gynae operations at Singleton. So a lot of work going on with Swansea Bay to address that as well. And then I was just going to briefly recognise the excellent work being done by the ultrasonographers. As board will remember, we were sitting at well over 10,000 patients waiting for an ultrasound over 8 weeks. That's now down to 6,000. We are doing around 800 additional ultrasounds a month at the moment to bring that. So we remain on track to deal with that. And then clearly in terms of CAMS, we and linking with the Teach Lydiard presentation just now, the CAMS service is continuing to deliver a real improvement in access and continue to do so the first appointment now is well up into 80%. Challenge is then the capacity to do the treatment planning, but that remains ongoing improvements with our CAMS service. I think the other issue I just wanted to flag clearly is around the stroke performance, and the stroke performance isn't at all where we as a health want it to be. I think it is indicative of the challenge we have of running two very small stroke units. We only have 4 stroke consultants, 2 on each site. We've just gone through another round of recruitment for the 3rd post of Prince Charles and have been unsuccessful in recruiting. We are in recruitment phase for the enhanced expansion of the early supported discharge programme, and looking at some of those stats, it is a real challenge insofar as we now are protecting a bed on both sites all the time for stroke access. So there is always an empty stroke bed, and some days there are 2, maybe even 3. So we're protecting that capacity. That it's reflecting is that the processing of the patient from arrival to get to the ward, actually it's identifying that there is more of a challenge within that process, and that's what the internal stroke group is working on, is that ED process, so that we can get the patient seen, thrombolyzed if appropriate, and moved to the stroke unit within that 4-hour window. So that remains ongoing, and we're also working with Cardiff to explore again the option for a regional stroke rota for our stroke physicians. It's a very, very intense rota, particularly with the number of calls, not just around thrombolysis and thrombectomy, but actually it becomes so our stroke physicians who work on a 1 in 4 rota are feeling exceptionally pressured, and we need to reduce that. And so we're again in conversation with Cardiff about that. I will leave it there, but happy to pick up any questions.
Thank you. Thanks, Gethin. Ian, I think you indicated you want to ask a question, and after Ian, I'll come to Geraint.
Yeah, thanks, Jack. Can you hear me?
Yes, we can.
Yeah, good. Yeah, I got a few questions. Some of them were touched on there by Gethin when he was going through that. But the first one I've got is on a quality improvement on stroke. So I won't ask the detail stuff because Gethin covered a lot of it. But I was wondering that it mentions in the narrative about AI software called Brainomix, I think it's called.
Yeah.
I was wondering if maybe you know a little bit more about that. It seems very interesting. I have done my sort of research outside this meeting and looked into what it does, and it looks very promising in terms of what it does. Maybe you could expand on that. I would add the funding for it seems a bit fragile. The other thing on that was it said that there was no admin or systems support at Princess of Wales for data quality. So maybe you could comment on that as well. On to other items. Sorry, I got a list here, so apologies for that. On Fund B, the graph that we've been presented there on Fund B, I think it's page 62 in the top right hand corner. It looks like the graph hasn't changed from board meeting to board meeting to board meeting. Now, I don't know if it hasn't been updated or if it's because ophthalmology is so huge along the bottom that we can't really see the changes on the other parts of it. If that's the case, could I suggest, in terms of data presentation, you use a log scale on the x-axis, and that might make the data look a bit better. And the last one was on mortality index. So that was on page 70, I think. It's good to see the figures on mortality index. I would say they may be not granular enough at the moment for us to be able to make informed decisions about what's going on. I'm thinking particularly about the tragic case up in Chester Hospital. What we can't see at the moment is we can't see mortality in different areas of our hospitals. It's just general for the whole health board. Are we able to do that? Because I think we need to be able to see alarm bells going off if something like that would happen to us. And we can't see that with the overall sort of higher level data. So that's it. Thank you.
Okay, thanks, Ian. I'll bring Gethin in first, and I'll come back to Sally on the mortality data.
Yeah, so in terms of Brainomix, I think Stu's happy to tax the answer up on that one, but
Especially that first thing, you're absolutely right, Ian, in terms of the solution. It's incredibly positive. It's been around actually a little while now, probably about 18 months, 2 years, when it was first presented to chief execs in NHS Wales, and there was a universal support to implement. But as you quite rightly point out, the funding mechanism around it is quite challenging. So we're having to look at how we can safely implement within our current resource allocation around those sorts of things. So it's still on the work plan, but it's where it fits with veritable priority. So it has been referenced actually in the Digital and Data Committee as well when we talked about it as part of the Digital Assurance report. But I appreciate that's quite a lengthy report, as both you and Caroline know from last time. But so just to say, yeah, we are looking to implement, and how that then changes workforce models, because one of the things that we regularly do with digital change, isn't it, is we implement the solution but don't really do the service change element wrap around it. So that's one of the things that clearly this presents an opportunity with.
Thanks, Stuart.
Yeah, so I'll just pick up on the admin question, and so part of that work at the moment, Ian, it's about moving towards a single admin support to do the DQ for the whole stroke service, and recognising that we've historically ran 2 separate services. Part of this is around bringing the stroke service together, and the consultants now work a joint rota when previously we had 1 in 2 rotas, and so part of that is about we've got consistent application. you know, one of the things that we pull out of a lot of our internal audits are that we don't have a consistent process across all the sites, and therefore we create some of those DQ challenges. So that's an ongoing discussion with unscheduled care, but they're pulling that together. And I'll pick up the Fund B graphic presentation with Stuart, Linda, and we'll resolve that.
Oh, thanks, Sally.
Yes, you know, regarding the mortality data, I agree with you. We need more granular detail there, and that's something we're working on. So the medical directors team have produced a form that they want to introduce. At the moment, different things are recorded in different places where people die, so in different parts of the health board. So we're going to make that more consistent. That form needs to be electronic. It's gone to ICT. It's gone to the project portfolio board there. So I'm hoping we will get an output and be able to start that, and that then we should have more granular information about exactly what you're talking about. Regarding the Chester side of things, we do have a very good detail on neonatal deaths, and that is presented through the children and families performance, plus those dashboards are seen at quality and safety. So rest assured on that side of things, we have a very, very close view of what's going on. But yes, I would expect in the fullness, in the medium term, that we will have much more granular information about deaths and that we can present here.
Excellent.
And so just to pick up Sally's point around, you know, we have got a capacity issue as we're looking, not to go on about it, but in terms of how we prioritise these things. So if a clear steer from the board, for example, that this is a focus we really want as part of the presentation going forward, then clearly that bumps it up that prioritised list as well. So I'll take that away today.
Yeah, that's right. And also just to say that it isn't just about the data and the collection of the data. It's also then how the specialties use that data.
Yeah.
And one of the things we've also said through the development of the new care model and the clinical directorates we're creating is that we're going to move to a standardised agenda setting for the mortality meetings that each specialty has. So there'll be corporately mandated, if you like, expected things that people should be talking about, as well as specialty specific things that will be relevant just to their specialty. We will ask for a core set of things like mortality, incident reporting, ombudsman and coronary inquiries, complaints and concerns, that is standard practice for every specialty to be reviewing, as well as the sort of very specific stuff for that. So it's the data and then the process by which it's analysed and discussed is equally important.
Geraint and then Patsy.
Yes, can I refer to ambulance handover times, please? There are dates given in the report for the improvement programmes across the 3 district general hospitals. Can you tell me what, I mean, those dates are now passed in those, are those plans now being implemented? And in a nutshell, what are they?
So the plan specifically around handover, one is the implementation of the handover. So we've developed a handover SOP to set out what the expectations are, what the decisions have to be taken, and the use of that to support site managers, the nurse in charge, the doctor in charge within the emergency department, and how we then escalate beyond the emergency. So, you know, clearly the emergency department has a finite physical capacity, and one of the challenges then is having to move patients out to create some additional offloading capacity. So we will then make decisions around boarding against confirmed or probable discharges. So it's clearly laid out that there's a cascade of action on the action card linked to this to ensure that everything that is absolutely possible to do to move the patient to create an offload, because we try and within every emergency department we try and keep at least 3 spaces, because we know we will often be asked to deliver a red release, so we always try and have a red release space. We always try and have a resus space available, because a large proportion of our sickest patients actually walk in. they don't come by ambulance, which is something that is quite significant in CTM. You've only got to look at the strokes. Probably, I think, is it 40 to 50% of our strokes do not come by ambulance. You know, that's a number that's just unrecognisable anywhere else in the UK. And because and partly that's availability. The other part of that is that I don't think people fully understand that what their potentially their symptoms are telling them they've got. So we always try and keep 3 spaces. One, so we can always offload an ambulance. One, so we've always got a space where if someone is critically unwell, we can treat them. And the third space is we always try and keep a space so we can always honour a red release if it's given. And so all of that is, you know, when you think about the volumes of patients in our emergency departments, you know, some days we can be over 100 patients in any of them, then that becomes a real challenge. So the purpose of the SOP is to give everyone that tool.
Couple of questions. I'll start on the one you just touched on. Actually, there's no red release data, and I know it's a lot better now. It's massively improved, so we should be celebrating it and seeing it, and that would be really good. On page 6, there's the colonoscopy procedure, and I know you talked about endoscopy. I know we talk a lot about JAG accreditation in various meetings, but we never really focus on the consequence of those issues. And I wonder if in the quality and safety, with Chair's consent, that we do a bit of a sort of look at the consequence of the colonoscopy data, because I mean it's incredibly low against a target of 90%. So I think that would be helpful. And a couple of things on page 28, never events. I know there are very few, fortunately, but are they sort of discussed in a committee somewhere, so the board is assured that there are no trends, that that whatever the never event has sort of been about, it's discussed and understood, obviously observing confidentiality, but that the board then have the assurance that whilst these never events are very rare, as indeed they should be, that there is an assurance around that for board members. And then the final point, again, is on a similar theme on the nationally reportable incidents. CTM is massively different, nearly double the other areas in Wales. And I wonder if the criteria is slightly different. I know we are continuing to report against the locally reportable incidents, and that's not required now nationally, but that national figure is massively different. So I think, if I remember correctly, we're 74 and the next one up was 42. So huge, nearly double really to the next one up. Yeah, so I just think it'd be helpful to understand why there is such a difference with CTM's national reportable incidents and the peers.
Right, did you want us to do the clinical execs? We're going to do an update on the quality metrics.
Yeah, I was coming to you next. I was coming to you next anyway. But did you want to answer that question?
To cover that now.
If I answer that first, then.
Yeah, that would be useful. Thanks.
So are you talking about the benchmarking graph we've got there? Yeah. So the 74 are the number of incidents we've got over the closure date of 90 days. But it's not the total number of incidents. In terms of where we benchmark nationally, we're very much in the middle in relation to per 1,000 patients per head of population in relation to NRIs. But that 74 mark is the number of incidents over the closure date.
Thank you. Getting anything else on the other points that?
Well, I think the question of the understanding the consequence of delays with endoscopies is you know, clearly we risk assess as you know patients and but you know there's always a risk. So I'm very happy that we picked that up through QNS, and we'll bring a report.
Okay, unless anything else to get in, can I
Greg, can I come back to you then to the quality part of the report? Yeah, thank you. So we had a good run through most of the quality metrics week. So just a few things really to bring to the board's attention. The first one is the still my nagging concern around some of the challenges with our gram-negative bacteremia levels, particularly E. coli. So you'll see in the report that we're still challenged with the numbers of E. coli patients in the community as opposed to patients within the sites. And for those of you that difference that E. coli is essentially a bug that sits in the lower intestine and can sit there very happily generally, but for some patients it can be really challenging and that can lead to mortality in the most vulnerable of patients. Now there is a growing trend, a national trend of E. coli raising across Wales, and particularly C. difficile, MRSA and Klebsiella. We did have a summit with the Chief Nursing Officer last week as nurse directors across Wales to get some more insight into what's happening across Wales in relation to the rise of these healthcare associated viral infections. So there's definitely something of a significant shift. From our perspective, nearly 80% of the E. coli infections come into the organisation, generally with urosepsis, infection, or gallstone issues or infections in the tummy. So there's not very much we can do in relation to preventing or mitigating some of the challenges within the community. That said, we don't have a community IP&C led team within CTM. Our team's currently very much focused on the internal challenges. Although Richard, my very able deputy, is working with the IP&C team currently to create some capacity to go out into the community, because I am concerned about patients in care homes, patients in their own homes, some patients that are under our DN service that need lots more support than what we can currently provide. So that Richard's doing that work currently. So a bit of a concern, we've got a plan, but we need to keep it on the board's agenda. Good thing to update the board is our 30-day compliance with complaints, up to 71%. The team's worked incredibly hard to get us to that level. We were at 30% back in January, February, March time. So we need to strive to get to the 75% magic target line, and then we're going to stretch ourselves to get to at least 80 or 90 going forward, because we don't want people waiting too long for a response. And then finally, from my perspective, we talked about the NRIs. We're not in a good position in relation to closure on time. Patsy made that reference earlier. We have made some drives to improve that, as you can see, over the last couple of months. Just to assure the board, though, when we do have a serious incident, there are always rapid reviews that take place. So any immediate learning will be shared with the teams and with the family. So we don't wait for a closure of a report to share the learning. So lots going on in the quality space. I still do remain concerned with patients that are in uncommissioned areas, patients that are crowded in ED, and regrettably there are still lapses of care that happen, but the incidence rates are very low. So just need to remind the board that whilst we've got some good quality metrics going in the right direction, some good performance metrics going in the right directions, our hospitals are still full to the brim and the experience isn't that great in some areas.
Thank you. Thank you, Greg. I appreciate that. Okay, any questions to Greg on the quality section of the report? Okay, I'm conscious that quite a lot of this does get picked up in our quality and safety committee by virtue of the amount of detail that is put there. Okay, unless there are any questions to Greg, can I ask Howell in terms of the workforce side of things and the important bit?
Indeed. So just a couple of things I wanted to pull out, and just for ease, I'm looking at page 24 of the integrated performance dashboard report and page 64 of the full bundles. There's just two things to note. So I should say there is a much fuller workforce report, people report, that goes to People and Culture Committee, and that's a good area in there. But just a couple of highlights. Sickness has been stubbornly high and challenging for us, I think, since back in 2020 in terms of going into the pandemic. So if you look at the graph in the top left-hand corner, you can see where it spikes up. And it pretty much, aside from a few fluctuations, has stayed stubbornly high for the last 2 to 3 years. However, there is a slightly encouraging downtick in sickness at the moment. So we're seeing around about a 0.5% reduction. It does say 1.6 points. It's actually 0.6 points. Maths and HR people sometimes doesn't mix, but it is 0.6, not 1.6. So we are seeing a slight reduction in sickness year on year. I'm more interested in the year-on-year reduction than I am on month-by-month fluctuations. Sickness will fluctuate month on month. But to have a 0.5% effectively reduction on where we were last year, given how stubbornly high it has been for 3 years, is encouraging. However, that's only a short number of months, and we just need to keep an eye on that. I hope that will be a trend and starting to see it normalise down to pandemic levels. We were a high sickness organisation pre-pandemic anyway, but we've been around about the 7.5% mark, and we're coming down below 7% now, which is really encouraging. Other things to note, PDR continues to rise, so the trend line on that now from our lowest point again in December 2020, we're now at our second highest reporting point in the last 4 years, so that continues to tick up slowly but surely. And also we are getting there now in terms of stat and man training compliance. You can see that there was a drop off in December 2022. That can happen again with stat and man training. People do it in a rush, and then a year later everybody drops off. But we are now seeing that tick up, and that is at 73.3% against a target of 85%. So we're getting there on that. The one that is giving me cause for concern, continued cause for concern at the moment, is the nursing and midwifery turnover, which again remains stubbornly high. We have just this week had a letter from HEIW indicating that the Always Nurse Retention Plan has now been agreed, and that's been shared with us. So there will be some national actions taken on that, and then we will be expected to take some local actions. We are also concluding that, our own nurse retention plan, which I hope will be approved in October. And we've also been given some funding for a full-time position to work on retention from HEIW, which we're very grateful to them for. We've appointed to that in haste and accelerating our work on retention as an organisation. And there are a few things linked into the pay deal as well, which we hope will have an impact as well. But that does remain stubbornly high, albeit the last couple of months we've seen a slight downturn, which again I hope will continue, but we'll keep an eye on.
Well, very quickly on the attrition rate. There are some really good examples elsewhere in England of where health organisations have put in a range of measures to act earlier in order to try and reduce the number of nursing staff leaving those organisations. And I suppose as a health board, we often talk about prevention and early intervention, the benefit of that in a variety of different ways. But I think it's to what extent, I suppose, a retention plan or a retention strategy put in some practical things that I suppose get in early enough where we know we have staff who are thinking about leaving the profession. I mean, that is quite looking at the data, I mean, it is quite, if you compare it to the 21-22 financial year, I mean, particularly around the November-December mark, when it went up above 9%, and the stubbornness of that since that point in terms of the turnover rate is quite concerning. But of course, lots of staffing problems can get addressed, not necessarily resolved, but addressed if we reduce the rate of turnover.
Yeah, so I think there's a couple of things I'd say. I think that it's probably better to compare to pre-2020 because we saw a drastic reduction in turnover mid-pandemic because people didn't want to leave and didn't want to move to new jobs, and then that ticked back up. However, it is much higher than the turnover rate we had pre-2020. You're absolutely right about early intervention. So part of the work we've been doing in developing our plan is reviewing the evidence about what works and benchmarking. So that will very much form part of it. And we also have some good data now, not in huge numbers, but some good data on why people are leaving us. So we're having much more data come through because the data that we collect from ESR doesn't give us that intelligence. So we have much more of a sense now for that. We just need to very quickly now start picking off some of the quick wins, I think, within the plan and making a difference and hopefully bringing that rate down.
Much appreciated.
I'll bring you in, I'm going to bring Simon in as well after. Yeah, just to add to that, so one of the practical steps of our teams are working together on this is the Itchy Feet initiative, which happens quite a lot in not practically itchy feet, nurses that want to think they need to leave and go somewhere else. So it's called Itchy Feet. And we did that quite successfully during COVID and following COVID, particularly for our intensive care nurses that obviously had huge challenges in relation to caring for COVID patients in that high tech environment. Wanted to leave, but we moved them on to outpatients or working in the vaccination teams or working on the wards, and without going through the process of track and applications and all sorts of things. So our teams are working on the Itchy Feet initiative to ensure that we capture them and support them before they leave and go elsewhere. Something very practical. Yeah.
Thanks for your help. Yeah, and the other bit then is I think around flexible working. So, we do have some very old-fashioned attitudes towards flexibility. So we make decisions to decline application for flexible working when we then lose somebody and then we can't replace them. So we need the national approach to that has been to focus on policy. That will only ever get you so far. We need to focus on attitudes and culture around flexible working. I still hear things said like my manager doesn't believe in home working, for example. It's not a fairy tale, home working, it's a thing. So it shouldn't be about whether somebody believes in it or not. It's good. So we just need to fundamentally shift our attitudes towards some of these things and realise that actually by being flexible we will retain people. And then I think, as Nicola and I have discussed many times, the development side of things and career progression and opportunities is another area for us. It's tricky because we can't promote everybody, but often it's not about promotion, it's more about personal development and giving people those opportunities, which is why our L&D offer and our leadership offer is so important in terms of giving people opportunities to develop themselves.
So, and yeah, recognising and articulating the impact that our staff have is so very important. Now, Simon, you want to.
Yeah, just whilst on the people there, just want to let the board know that yesterday we launched the first stage of the CERN CTM Awards, our award and recognition scheme for the staff. We launched it at 12:30 yesterday. The first stage is the peer-to-peer recognition scheme, so enables staff to kind of recognise colleagues they work with for excellence in a particularly good piece of work. And as of about an hour ago, we had 150 submissions, so in less than 24 hours. So it really shows, we tapped into a seam with, running through this organisation where people really wanted the opportunity to be able to, say thank you and well done to staff they work with. And we've seen some really nice trends starting to emerge from that, where members of staff, managers are submitting CERNs for their team, and those team members themselves are then nominating others within their own teams as well. So something that kind of cascade of positivity through the organisation, which I think is really good. The second stage of the CERNs then is to collate the submissions that happen each month, and they will form then the shortlist ultimately for our CERN of the month. We'll have a panel which represents different parts of our workforce. And then the executive team will have the ultimate responsibility for picking our CERN of the month. So that will be another opportunity to celebrate. And then the third stage is the big kind of chunk, which is the annual CERN Awards as well. But just really pleased to see that's been launched. Been a bit of time getting there. There's been some technical hitches in the last couple of weeks, which were a bit of a struggle to get through. If you don't mind me saying, Chair, as Carl from my team is on the call, Carl's done a sterling piece of work to kind of navigate his way through some of those tricky pieces, and has built a process that is really, really simple, very, very intuitive, and we're seeing that borne out by the numbers. Just so really pleased to see that work underway.
Thanks, Simon. And to hear that progress, and admittedly, sometimes it takes time to get these things right, and I would rather see us get these things right. But to know we've got 150 people already who've been put forward, I think is phenomenal, and a good comms opportunity there as well to remind the organisation of this work, and to say that in a very short space of time we've had colleagues being nominated for consideration. Nicola.
Yeah, thank you, Chair. Thank you, Simon. It's great to see progress. One of the concerns that come from staff is the lack of recognition from the organisation. So whereas previously, if you've had a length of service, the organisation thanks you, as opposed to a thank you from your peers. So where are we with that work? Because that work, that can be pulled from ESR as it has previously.
Yeah. So two bits there, I guess. So the Seren Awards as well. So different to the long service. So as I say, the Seren Awards, the first stage that's live now, will enable peer-to-peer recognition. There will then be an organisational recognition for those who've done particularly exceptional pieces of work as well. So that will be the Seren of the Month Award. So there's a peer-to-peer bit, and then there is an organisation more. In terms of the long service stuff, so really pleased to be working with a member of Hal's team, Nick Carter, who's supporting me with that. We've got an action plan now, which Nick is working on with me. So that work is underway as we speak. And yeah, in the next few days, we should be have a bit of an update on where we are with the implementation of that long service stuff. We know we need to chip away at a huge backlog. So the first thing is to make sure those people have been sitting around probably thinking, well, where's my recognition? As you say, we need to make sure those people are recognised, and then we'll better get into those new members of staff who are coming through. So underway. There's an action plan that's being worked on as we speak.
Is there a time scale? Sorry, is there a time scale?
So
we can have an action plan forever. Same one.
Yeah, we could. So by the end of next week, I will have had a catch up with Nick, and we'll know. Better have a time frame from that. So I'd rather, if that's okay, come back and I can have an off after this meeting conversation with Nicola and update yourself on where we are with that after next week.
One final question: the panel. Will it only be execs sitting on the panel to make the decisions? Because I think there should be wider involvement in the panel to make the decisions.
That's exactly, and that's what I'm saying. That's exactly what I said. So the panel is drawn from staff across the organisation. So that invite's going out. We're asking deputy directors to nominate people within their team, and that panel will probably sit for 3 months, and then we'll refresh that. So different members of staff will have the opportunity to be involved in judging, shortlisting some of those things. And then the exec team will see a shortlist, but that shortlist will be derived from those panel members who represent the whole organisation.
Honestly, just on the long service, I mean, I know this has been a topic we've talked about for a while, and I think as Simon has highlighted, there's quite a bit of work to do. The challenge with all of this long service stuff is there will always be people that slip through the net if we're not careful, and so I think we just want to make sure that we get the numbers right. And I think as Simon's highlighted, there are quite a lot of people in this organisation that work many years. So we're conscious we've got quite a backlog of people to get to recognise. So I think what we're going to have to do is break it down into, I think Simon from what they say, we'll take 40 plus first, and let's do an event for the 40 plus, and then we'll go to the 30 to 40, then to 30 plus, and so it's going to be quite. When you get to the 30 plus, there's actually a lot of people. I sign all the retirement letters, and it never ceases to amaze me how many people are retiring with 42 years of service, 45 years of service. So actually, I think, but I would anticipate in the next couple of months, we will be in a place to be able to start to have the first of the new recognition events. Yeah, that's the plan. Set to 40 plus.
So the 40 plus,
we will start the recognition events to celebrate all those people's contribution. That's great.
Okay. Geraint and then Mel.
Yeah, how does staff want to be recognised? Have they indicated what they would like? In terms of, you've mentioned an event, so that's one way of doing it. But have they proposed any suggestions themselves?
From start in terms of the long service.
Yeah.
How are you going to?
Not on long service.
Sorry.
More generally, I was going to.
Yeah. So we know that in the past, when just prior to my time, when those events have been put on, they've been really successful, and we've spoken to other organisations where those things land really well with staff. Okay. The opportunity to be able to step out of their day-to-day work, come to a place where they are there simply because, to be recognised for the dedication that they've put in. So that plan is based on what we've seen from this organisation in the past, and from what's working really successfully in other health boards and in other trusts across Wales as well. But fair to say, I think, Geraint, and I've said this from the off, really, there's been a big gap here, and we really need to kind of start addressing it. We also need to carry on learning. So what we can't do is put in place the mechanics for a process and then say, that's it, done, wash your hands, and not touch it again for another 5-10 years. So we need to continue listening to those staff who are coming through those events, who are being recognised. Similarly with the Seren Awards as well, and constantly keep on tweaking it improving it as well, based on those staff who are experiencing it themselves?
If I just bring Mel and then Hal, I'll bring you back into the one.
I'll be very brief, Chair, to be honest with you. Greg mentioned the itchy feet syndrome and the stuff. This is another indication, because the people that we're not recognising, people want to be recognised, is the truth of the matter, whether they'll admit it or not, right? Everybody likes it to be recognised for 40, 50 years of work, right, in some way. And if they don't, that will result in the itchy feet, and there's also something worse, the way they talk about this organisation. Because let's not forget, as an employer, the culture is within our communities that they listen to the grandmas, the mums, the sisters, the aunts of what it was like working in the health service. And if they hear bad words, they don't want to join us. That's the truth of the matter. So never underestimate the power of people and what they think and how they feel when they work in this organisation.
One of the reasons why this work is so important. Yeah, and I think that's why we've seen this now happening at a pace.
Yeah, no, I'm just going to say now, I'm in the privileged position myself to see all of these Sarah awards that have come through in the last kind of 20 minutes or so, and it's absolutely borne out. There is a massive pride in the organisation. There's real pride in the teams and the colleagues that people work with as well. So as well as enabling people to celebrate one another, it's telling us something really, really useful that I think we can use to identify if we are delivering on the culture that we set out to deliver. And certainly from what I've seen, there's some really good indications coming out of that.
Good.
Oh.
Yeah, no, I was just going to say more generally. So the evidence on recognition is that these things are very, very effective at for those they touch. But obviously, we've got 13,000 people. The most effective recognition happens on a day-to-day basis in the moment when something good happens. So generalized thanks from organizations tend to be fairly ineffective, if I'm honest. Specific thanks about you've done a really good job on that specific thing you've done is the most effective. That's often the most challenging, because all of our staff, and most of our staff, work in extremely challenging circumstances, and that's the stuff that sometimes doesn't happen. So alongside what we're doing here, that's why the sort of culture balance piece is so important in terms of managing the leadership interactions with our people and recognising the good work that happens every day. So we've got to do both, I guess, is what I'm saying.
Thanks, and just to remind colleagues that as part of the work that this health board is doing around supporting, encouraging, and developing our staff and developing our staff models, tomorrow we have the launch of our strategic plan to support recruitment and development of those who are our allied health professionals and scientists. And looking forward to that launch tomorrow. Again, a really important part of looking to the future as to what those workforce models look like, recognising that the workforce of the NHS now is fundamentally different to where it was 75 years ago. And the development of those professions, again, is really critically important. So just to remind colleagues, we have that launch tomorrow at 10 o'clock, and a very exciting way to almost bring the working week to a close. Not quite by 12 o'clock lunchtime, but on a Friday. It's a great way of coming towards the end of the working week to celebrate the role of our HPs and our scientists, and saying that this is where we're heading in the next few years. I'm conscious of time. We're going to stop shortly for a break, but do other exec directors have anything they want to raise at this point in terms of performance? Nothing from you, Philip? Stuart, anything from you?
Nothing.
Lauren?
Yeah, it's covered off most things.
Yeah,
Thank you.
fine. Okay, thank you all very much. We're going to take a break for just about 10 minutes. We can return at 11:50. That would be very generous. Next 2 minutes.
Are we live now, Carl?
Yep, back.
Michael, welcome back to today's board meeting. We'll move on to item 5.2, which is the second part of our integrated performance dashboard, focusing on our financial performance. I'm going to ask Mark Thomas, who's here today on behalf of the Finance Director, to present the report covering month 5. The report covers a lot of financial detail around our projections and how we're meeting our financial challenges. Mark, I'll hand over to you. Thank you very much.
Thank you, Chair. This report sets out our financial position at month 5. And the only bit I really wanted to draw out from the report is the summary position on page 6 of the report, which is the year-to-date performance and forecast, which is actually 79 of the book. So if we could go to that page, please. And so yes, going through the key points. The month 5 position was a reported £6.7 million deficit, and that was £100,000 worse than our planned monthly deficit of 6.6 million. However, month 5 was an improvement on the trend, so an improvement on the month 1 to 4 average run rate. And that takes the month 5 year-to-date position now to a 36 million deficit, and that's 2.8 million adverse compared to our plan. Key point is that if that current run rate now carried on for the rest of the year, the 2.8 million year-to-date overspend would translate to a 6.8 million spent at the end of the year against our 79.6 plan. However, we've got forecasted savings plans coming in for the next 6 months, which are showing a step up in trend over the first 5 months of 3.2 million. And we've also got a plan for delivering the other 3.6 million. So at month 5, we're maintaining our forecast for the year to be 79.6, which is in line with our draft financial plan at the start of the year. Forecast assumes that we'll receive 9.3 million of funding from Welsh Government for ongoing COVID programme costs, and I think it's fair to say that that's a low risk. However, the 79.6 million forecast is not without risk. We've highlighted 2 key risks to the forecast on page 16. And that comes to 8 million. 4 million of that relates to the arbitration risk with AV Health Board, which we've yet to have an outcome from Welsh Government. And we've also got several funding risks associated with assumed funding streams from Welsh Government. So in addition to delivering the 3.2 million step up in savings, we've also got an 8 million sort of risk profile to deliver our plan. So that's where we are at month 5. And then the last point to highlight is that we are still awaiting a response from Welsh Government on our proposals. We submitted our proposals for 10%, 20%, 30% improvement. We haven't had an outcome yet, but it's very likely that we will be asked to deliver an improvement on the 79.6. Stop there, but happy to take any questions.
Thank you, Mark, much appreciated. Garrett?
Yeah, can I just ask then, 79 million at the moment, if this isn't a crude question to ask from a local government representative, where we have to set balanced budgets every year, where does that would be a transfer from reserves to cover that, or what? Where would what would happen? Where does that money come from?
Effectively, if any health board exceeds its financial allocation, then what has happened in the past is that the Welsh Government has, through a variety of different mechanisms, effectively covered that overspend.
And what they write a massive IOU, or we write a massive IOU. How does it actually work?
I think there's at the Welsh Government level, obviously, there's the NHS budget. I think it's the MEG, and they've got to bring in the MEG budget in totality. Now, there are overspends I think, across all of the health boards. I don't know what the position is at the central Welsh Government level, but the challenge at the Welsh Government level is how do they bring in the NHS Wales position? If that doesn't come in. I guess there's lots of conversations going on at Welsh Government around budget allocations between departments and moving things.
But it doesn't get written off, does it?
No,
That's the thing. The in-year deficit is covered off, but that deficit position is then carried forward. So what we as an organisation have to do is to as Mark rightly highlighted, we are in exactly the same position as every other health board in Wales now, where all of the health boards are carrying forward significant deficits. So the challenge is to think about how do we build a 3 to 5 year ongoing financial plan linked to our clinical services plan as well, to say how do we restructure and reorganise our services to try and bring us back into a position where we are going to be financially sustainable over the next few years.
Can I just make a couple of points in respect to the report? Firstly, I think the fact that after month 5, we're still able to say with some confidence that we are still looking at that 79.6 million overspend. I know that that has been particularly more challenging in other parts of Wales. I'd like to place on record also my thanks and acknowledgement of the fact that with a £27 million savings plan, at the moment we're projecting 22 million of that is deliverable. I accept that there's still work to be done. However, that itself is quite a significant achievement because people tend to forget that to deliver the plan requires the delivery of the savings plan, and that in itself is there's a lot of work that's been done by the team to address the sorts of things that can be done to deliver those savings. So I think that at month 5, being able to make that projection at this point, I think is really quite a position to be in. I know that we want to deliver all of it, but at this point to see that I think is quite something. I think it shows you the level of work that's been done, the confidence that's been put into the system, and the robustness of the planning that's been done at this stage. And of course, we did submit our plan as requested by government to address how we could reduce the overspend by 10, 20 or 30%. We are waiting for official confirmation as to the outcome of that process. However, I understand that you as a team have been working on what that could look like if there's a further request to go to reduce that overspend.
And there's lots of work being done on the 10, 20, 30% proposals. I know Gethin's team has been meeting on that. We're finding those in terms of what's the state of readiness, what's the lead time from a decision to implementation. There's a summary of that work going to be going back to the executive group in 2 weeks' time.
Final point for me, and I know this may sound a bit strange as we're only halfway through the financial year, but next year concerns me, the year after that concerns me. And it's what work, and I've said this to Paul a couple of times, it's what work perhaps now as a board we could be doing collectively, fairly soon, before the end of the calendar year, to think about what next year could potentially look like, knowing what this year's looked like and what that means for our own plans for the next financial year. Because I don't know, we will do this, but obviously no organisation would want to just get towards the end of the financial year and then go, well, we haven't done any planning for next year. I know those plans start early, I know the consideration of that starts early, but I think looking at the financial position of the NHS, I think therefore the urgency on us as a board to do that work sooner rather than later is certainly there. And I know you and the team and Sally will be thinking about that. But I think that's a collective thing that we'll need to do, to engage members of the board in that work.
Yeah, I would also just say that we're going to talk a bit about the CTM 2030 and the clinical services strategy. There will be things that maybe we need to accelerate into next year, which will, because fundamentally a lot of the structural challenges we have in terms of the service models, we're trying to resource across 3 sites. Part of the reason why we're running quite high cost and overruns on our spend in some of these areas. So there may be areas where we need to start to bring forward some of those plans sooner than later, but recognise equally that we need to do it in a way that's inclusive and engaging of all of our clinical teams as well.
Absolutely.
Get it. Well, and I guess that's where the value of doing the 10, 20, 30 has been, because actually what it has started to develop, even if they're things that we can't do this year, they have begun, that process has begun to populate the pipeline for next year and the year after. So actually what we're seeing through that process here are schemes that have potential some delivery this year, but actually will then increase and expand next year and the year after. So I think absolutely recognising the scale of the challenge for the next couple of years, we've got to be working in far more around that transformational service delivery plan rather than just looking at salami slicing individual costs on a year-by-year basis.
Sure, yeah, and just to say conversely, I suppose, you know, we, as well as accelerating a number of things, we may have to make some difficult decisions in the board about what we deprioritise and spend. You know, I'm really conscious of that from a digital perspective, and certainly when there's expectations both, you know, nationally and locally, I guess, in terms of things that must happen. And we are, you know, so just with that in mind, and I know we've got the highlight report to come, but we did start to have a conversation with the Digital Data Committee, Caroline and Ian were there last time, about some of the national programmes of work which we might need to make some, which will inevitably cause some frustration and noise in the system. I just think it's important to flag that at this stage.
That's it. Yes, Mark. Yeah, just to reassure everybody, we are already thinking about next year. We are using the month, it's early days obviously for this year, but once we get to month 6, typically then we go into next year's position, and I think we'd be sharing some initial sort of framing of what next year looks like, probably in the next month or so.
Yeah. Any question, Patsy?
Yeah, just a general point really. We talked about the 2030 plan. That's particularly important because the health board will keep that 79 million deficit or whatever it turns out to be, because the legislation is for a 3-year rolling break even. So that, and indeed last year's, and whatever happens next year will stay with us over and over. So it's that forward planning that is so important.
Yeah, and I'd also say, and I know we've had this position in exec team as well, because currently, you know, we are, well, our number is pretty, we are in a relatively controlled position on our plan at the moment. And, you know, not about looking over our both shoulders, but there are other organisations around us where the number is going out quite considerably. So then what we also have to guard against is that we end up carrying a higher level of efficiency because we can, it's perceived that we can, where others aren't able to. And then we highlighted, came out, I think when we had the conversation about the 10, 20, 30%, that very clear that we didn't want to see a situation where our population became more disadvantaged in the allocation reductions than neighbours. And I raised that point with Welsh Government and Julius, and it's very clear that whatever ask was put out there, it needed to be equitably applied across all organisations, and that you can't expect one organisation to carry a higher percentage of efficiency than another. But when you're looking at some of the numbers that we're looking at across other health boards, it does begin to come into sharp relief that some people will struggle to deliver their existing plans, let alone go beyond those plans, which then makes the question, well, how will we handle it anyway? But it's just something I think we need to be alert to and just keep an eye on. And I know Mark and Sally are very much on that as well.
Okay, any questions or comments on the finance report? Okay, thank you. The board resolves to note the report. Thank you, Mark. Item 6, governance, risk and assurance. In terms of item 6.1, we covered the escalation status in the chief exec's report. So unless there's anything on that, I'm proposing to move to item 6.2, which is the board assurance framework. And I'll ask Gareth to present the update report, which was received by the ELG on the 18th of September, before I ask board to consider and approve it. Thank you, Gareth.
Diolch, Cadeirydd. Thank you, Chair. Yeah, I'd just like to say a few words in terms of introduction to the update on the board assurance framework. Firstly, just to remind the board that the framework itself is underpinned by our organisational risk register, which there are a number of cross-references in the framework itself. And that risk register is available to all members all the time on the further, and I know they get attention at all the relevant subcommittees. Specific risks. In terms of the updates themselves and the framework, I'd just like to record my ongoing thanks to Callie, the Assistant Director of Governance, my team, who's done a lot of work to embed, obviously, this framework within the organisation, and to Philippa as well, who's prepared this update report today. and also the colleagues around the table who are the strategic risk owners, and we've worked with my team to ensure that these are updated. The relevant updates are highlighted in red in the report, so we should be able to see where those updates have been made. And I do wish to draw the board's attention to the one substantive, really substantive change, which is the introduction of a new risk 10 on healthy life expectancy, which is being proposed to be escalated to the board assurance framework. And our colleague Philip Daniels, the Director of Public Health, is the strategic risk owner of that particular risk. That's all I wanted to say at this point, Chair, and then obviously open up to any questions or comments for the relevant exec.
Thanks. Any questions or comments from colleagues? Philip, anything on that particular risk you wanted to touch on?
No, I mean, I'm glad that it's actually coming to the risk register, because I mean, it's pretty central to what we're trying to achieve as a group, really, and recognising that if we don't act now, then we will be unsustainable in the future. Clearly, the numbers around it in terms of likelihood and impact are largely academic, but it's good. It's good that we've got our eye on it, and that it is justifiably rated high enough that we will continue to return to it as well. So it gives a good platform to talk about the wealth of prevention, primary, secondary, and tertiary, that we're taking as a health.
Well, can I just, yeah, I mean, I think it is really important we put these sorts of risks on the risk register, because we're not just about the risks that sit with the things that we do as a provider.
Absolutely.
We are about population health focus, and I did make this point earlier in the week at the leadership board, then when the Welsh Government colleagues, when they talked about the escalation framework, saying no good just being escalated around performance around our direct provision of services. We should be also challenged about, are we doing enough to tackle some of the health inequalities? Are we doing enough to support family care development? So the fact we're starting to identify these risks, putting them on our risk register, I think is a really positive endorsement of where we're trying to go as an organisation.
Absolutely, and I circulated a paper on to a few people. The chief scientific officer published a report looking at what the NHS would look like in 10 years, and how we are going to have to shift, not only as an organisation but also as a system, and how we work with our communities, etc. Because we're not going to be able to sustain what we do, and we're not going to be the same organisation in 10 years as we are now. So,
yeah, I've asked for that document and for the paper to be circulated to the board colleagues, because it's the first time, certainly since my appointment as chair, that I've seen a national viewpoint as to what the health of the nation is likely to look like 10 years from now. And as one of the health board chairs who's been suggesting that there ought to be a national view taken by government as to what health and care needs to look like 10 years from now, well, quite frankly, the document produced by the chief scientific officer ought to really underpin and inform and drive that. So it's a really useful read. So I've asked colleagues to check that once it gets into your inbox. Now,
I totally agree with this. There should be on the risk register. But I would say it needs to go even further than just being the health board. It's not the health board. This is a multi-agency, and I would say, Chair, if you could influence what chief executive and leaders of any organisations that we work with, included. But this is something that we all should be held accountable for.
Yeah,
not just the health board.
So Philip is doing quite a lot of work at the moment with 3 local authority chief executives and leaders group on this agenda, and we're also looking at PSB as well. And maybe what we could do, perhaps Philip, at some point is in one session is perhaps give an update on the work that he's going on with the local authority on this topic. We are trying to. The challenge with all of this is it's such a broad topic area. You know, we can spend a lot of time on it and actually not make any achievements. So what I think Philip's helping trying to do with the local authority leaders is pin down to a few key things. What are the actual concrete things we could do collectively to try and make some inroads into some of these measures? So maybe we could perhaps bring an update to the future.
Thank you, Chair.
It's good to see this being active as well. Okay, any questions or comments? No, can I ask if the board approve the paper that Gareth has submitted? Thanks to Gareth for providing the report this morning. Yes, thank you very much. Moving on to item 6.3, board committee and advisory group highlight reports. They've been included on the main agenda as there are matters included in the reports that might require escalation to the
to the board. I'll start first with the Quality and Safety Committee report under 6.3.1, and Carolyn is chair. Thank you.
Thank you. So the paper you've got is, I think I reported verbally on that at the last board meeting. The committee met again on the 21st of September, so last week, and just a couple of things to highlight. We received an update on the work being undertaken to address the ophthalmology backlog, obviously getting to refer to that earlier in the meeting. And whilst members took assurance from the position reported, we also felt it needed to be very closely monitored because of the potential harm, and that may be something we would want to look at in more detail, possibly at this board, as well as quality and safety. We also received a report on the closure of the maternity and neonatal programme, and members endorsed that closure, given that the service has been de-escalated. So that will go back to routine monitoring through the care group now. Similarly, as we've heard today with regard to T Lydiard, that report was very much welcomed, and the fact that the service has been de-escalated, so that will also now come back through the routine care group monitoring. So they were just three key issues I wanted to highlight.
Thanks, Carolyn. Any questions to Carolyn on the update? No. Thank you very much. Thanks, Carolyn. Again, the board resolves to note the update provided. So thanks to colleagues on that committee for the work that's been undertaken. Can I just move on to the Population Health Partnerships Committee highlight report? Again, Carolyn, back to you for this one. And again, if there are any matters that need to be escalated, then I'll keep that's a chance.
I think nothing I particularly want to raise. You can see the item for escalation, which was a positive escalation on the recycling project. You can read the other items there. There wasn't anything particular that I wanted to go through unless anybody's got any questions.
Thanks. Unless there are any questions from our colleagues, we're happy just to note the report. Thank you very much. Item 6.3.3, Digital and Data Committee report. I'll hand over to Ian to update members on the work of the committee, in particular anything following the meeting held on the 12th of September.
Yeah, thanks, Chair. There's a couple of items. I'll be quick in the interests of moving things along. First, I've got a couple of positive escalations. Members should be made aware that we've now got a head of information governance who started on September the 18th, I believe. So that's a very positive bit of news. As we know, we've been trying to recruit to that post for a while. The other issue that people need to be aware of is that we've got a couple of issues to do with the Bridgend disaggregation. We have had a number of SLA, service level agreements, that were with Swansea Bay previously. They're now coming over to us. So we wish the committee to be aware that any resource released from that, we'd need to sort of ring fence them, so to speak. Otherwise, we won't have that equivalent service in our health board. So we wanted to bring that up to the attention of board. And also, we've now got a new target for the ICO action plan. This has been ongoing for a little while, which people might have been aware of, and they've been very patient with us. So we've now got a new target of January the 24th in order to tie up all those various different actions that were put against us. Hopefully, the head of IG will be on that one immediately. So the target should actually be doable. And there was one positive escalation I omitted, sorry, and that was that despite many challenges, we wanted to commend the team, the digital team, because of the completion of several infrastructure projects, even despite resources and various other issues that they had. So that we'd wish to make the board aware of as well. And that was it.
Thanks, Ian. Stuart.
Yeah, thank you, Ian. And just to complement what Ian was saying in terms of some of those items, the SLA, clearly we're working with finance colleagues on that at the moment as well, in terms of what opportunities there are. We do recognise you don't just take the service over and it doesn't just carries on happening. So I think, yeah, as Ian said, ring fence is a tricky word, isn't it? But I suppose in terms of how we're doing it, it's just looking at what are the critical services we need to still maintain, and actually how we do that with the resources that we've got at our disposal, and one additionality that does cause us, I suppose. So that is a work in progress, and working closely with Mark's team on that. And just to assure actually further, and you're right, Ian, and in fairness, since Claire's arrived almost only a week ago, we've made some quite significant progress around the ICO action plan already. Closed out about 10 actions in a week, so that's really encouraging. There are some really long-term process changes that will not be closed out by January. to be fair, the Commissioner's expectation is they wouldn't be, but significant progress against them is how they framed it. So feeling very assured and confident at this stage. Claire, myself, and meeting with the Commissioner in the next week or two as well, just to update on where we've got to. So
thanks, Ian. Thanks, Ian. Any questions to Ian on the report? No. Board happy to note the report. Thank you very much. The final committee report this morning or this afternoon is the Planning Performance and Finance Committee highlight report for the meeting of the 22nd of August. Patsy, thank you.
Yeah, much of it in the high escalation box is month 4, which I won't go through because we've just been talking about month 5. The one thing that remains relevant is the cash position that Sally, Mark and the team are well aware of the potential for needing strategic cash support, and will have developed a plan long before we get to that position.
Thank you, Patsy. Any questions to Patsy on the update report? No. Board happy to note the report. Thank you very much. Item 6.4. Before asking Greg to present the report, which is the Audit Wales and Healthcare Inspectorate Wales Joint Follow-up Review into Quality Governance, can I welcome Sarah Utley, Darren Griffiths and Vanessa Davis, who are joining us online. Very good to see you this afternoon. Thank you very much. Greg, I'll hand over to you. Thank you.
Thank you very much, Chair. So we had a good run through this report from Audit Wales and HIW board development session a month or so ago. Just a few things to pull out then. Since the review in 2019, this report states that the health board's made significant progress across the domains of quality governance. So really pleased that we had that response. Out of the 14 original recommendations, 9 have been fully delivered, verified and validated by our external colleagues. 4 requires some further work, and 1 of those recommendations have been superseded. We changed our operational structures. At page 5 of the report, you'll see some detail in some of the key actions that we further need to address, which align to the 4 incomplete recommendations. And as always, we'll track these through our established governance processes. And obviously, as Paul mentioned at the beginning, we have been de-escalated from TI to enhanced monitoring for all of the domains of quality governance. So that's it from me. Thank you very much.
Thank you, Greg. Much appreciated. As we've got Sarah, Vanessa and Darren on the line with us, do you want to add anything to that?
Well, thank you, Chair. I would just like to thank colleagues again for their support in undertaking this work. And as Greg's quite rightly highlighted, the report is positive, and we've found that there has been significant progress in addressing the concerns and recommendations from the 2019 report. And there's a much stronger focus on quality and patient safety, and the clarity on roles and responsibilities as well. Obviously, there were 14 recommendations, and as Greg's quite rightly identified, we've closed a number of those. There is a number of the areas that we've highlighted in the report on page 20, and we just want to continue to keep a focus on those. So we would be helpful to receive a written update from the report in 6 months' time, just to continue to identify the progress that's being made on those outstanding areas. And the review team's here, so if any members did have any questions on the detail of the report, then we're quite happy to answer those.
Thanks. I'll just bring Paul in at this stage. Thanks, Paul.
Yeah, thanks, Sarah. So I suppose what we I just wanted to check with you how, in terms of that update in a few months' time, are we going to be channeling this through things like structured assessment in the future? Is that the way in which you would see this being handled? I guess it's trying sort of, when you mentioned in the report there about moving to routine arrangements, it's just for us making sure we understand where the right route through to go for that would be. I'm sure you've probably had this conversation with Greg and others, but I just wanted to check with you.
Yeah, I mean, we will pick up a number of the areas through structured assessment, but I think we were thinking that maybe just a letter back from the health board, just to kind of identify the progress that's been made, just to kind of formalise that a little bit more, just so we could kind of close that off. I mean, we haven't made new recommendations, but we just thought that kind of update letter back would be quite useful, and then we could kind of close those recommendations down through the audit and the risk committee tracker as well. So it's kind of like a bit of a two-pronged approach, but it's probably worth having a conversation offline just to nail exactly how we do that.
Yeah, that'd be useful.
Thanks, Simon. Any board colleagues have any questions? I know we've been alerted to these reports and we've had them circulated. So unless there are any comments or questions, I'll just ask the board to note the update from Greg and to thank colleagues once again for the enormity of the work that's been done to respond to these challenges and see the positive progress we've made as an organisation. So thank you very much indeed. Okay, thank you. We'll move on to item 7, strategic planning, item 7.1.1, our CTM 2030 clinical services plan. Linda, I'll hand over to you for an update, and obviously, conscious that we've got some ambition here that we're putting together, a lot of engagement with our staff, with our colleagues, starting to think about what the future is going to look like, how we're going to reshape and redo what we do as an organisation. So exciting time, challenging but exciting, and I know we've got a lot that we want to get done. Thank you, Linda.
Thank you very much. It's not dull. So our actual text is going to be the second slide, because I think that's a helpful summary of our process, and it's a prompt for me to talk about where we're at the moment. Thank you. So we're back with our progress report following having approved at the end of July that we were going to go through this process. So we're in this section now, August to December. And you can tell from the other slides, I won't go through them, but we're right in the rough and tumble now with the services of gathering all of that information that you can see on those following slides about every service. And there's a lot of services. We are expecting that all comes in the middle of November to a degree that's enough for us to start to group issues and start to collate the suggestions that the teams are making, in order by the end of December to have formulated some scenarios for how things might be organised differently, what we might be doing to achieve the vision that we set out. The vision and principle slides are unchanged from what you saw before. We are continue to talk to our community representatives about that. We'll collate, we had some comments, but we'll collate all comments and agree those towards the end of that period, up to November, as we engage with more people. The other thing that you've got in the slide deck is the governance that we've put in place and how we're sort of managing this as an exec team and our direct reports. And in fact, yesterday we actually had a great meeting with the deputies group, which are the people that are going to have to pull together everything that I've just said and start to turn it into some numbers around, we talk about heads, beds and meds, don't we? If we do that, compared to what we're doing now, for each of the services, and then at a macro level, what does the jigsaw look like? And what's it, have we got the space? Have we got the people? What's it going to cost us? So we are going to be doing, with that group that I've just discussed, we're going to be doing a couple of dry runs so that they're match fit for when we've got the proper data. So we are going to work on some scenarios for them to model, just to get ready to do so in anger. So I'm slightly nervous about that, because if people hear that we're modelling scenarios, they'll probably think we've decided already, but it would be equally remiss not to have a go and learn that, what information do we need and what haven't we got. So just giving people a bit of a heads up around that. So we're on course. Oh, sorry, could you just go back to the timetable one on number 2? So we're on course at the moment. Obviously that period, January to February, which is the formal sort of, digesting of all the data, doing numbers and turning it into some options, which we then take back out to staff, is going to be quite intense, and it's an intense time of year. And of course, we're asking people to do this baseline exercise now, right at the beginning. Well, we're using it for the annual planning process as well, but I know that some of the teams are feeling quite pressured, because we're also pointing to posts and things like that. So, but there's never a good time. And of course, our hard stop. Well, there's 2 reasons for a hard stop and a bit of a hurry up, isn't there? One is that we're dealing day to day, we're overspending day to day and overstretching people day to day because we're not organised great. And the other is we're just trying to get it all in before the purdah associated with the general election. Obviously don't quite know when that will be, but assuming that's the back end of next year, that gives us, you know, something to aim at. Expect to hear more a lot.
Oh, and then, okay. Just in the highlights, just in the content zone, slide deck talks well, leads to the regional working. I think I would just emphasise there, it's becoming ever more evident to us, I think, that we can't design our clinical service model in isolation from our neighbours, and particularly Cardiff, because of A, the tertiary links back and forth to Cardiff, but B, also Cardiff's ambitions are almost intertwined with ours as well, because as they start to look at what they do as a specialist tertiary provider, they're also asking questions about, well, are there other ways they could be delivering some of the more DGH types of things that they do in partnership with neighbours. So clearly we need to be alert to that, because otherwise we're going to design our services and perhaps not take into account some of the expectations they have. So there's a workshop on the 11th of October, which it's been slightly delayed, hasn't it? But there is a workshop imminently where we will share where we're getting to in our thinking and our strategy. Cardiff and AB will do the same, so we can start to see where it's a bit like that Venn diagram. Where's the grey crossover hash bit in the middle that actually crosses over everybody? So we need to have some thoughts about that. And of course, LHP is a part of that solution, but there will be other services that would be sensible. We've already had a conversation this morning about stroke, for example, where actually it may be that we actually need to be more structured and formal in that approach to stroke services. So I suppose it adds, in some ways, it adds a layer of complexity we could probably do without, because it's complex enough to do it just internally. But I don't think we can do it without regional conversation. And as we move to more and more things being delivered regionally, it's essential those things are aligned.
Cameron, and then.
Thank you. So this is clearly a hugely complex piece of work and hugely essential piece of work. In terms of all the things that are feeding into it, the things I think we have to not lose sight of. So though this is about acute clinical services, our conversation about population health, life expectancy, etc., we have to be planning services based on how we want to change those, so that you know, we're not just designing services for now, where are we going to move to? And the other thing which I always find on about is research, and how are we putting research into this? And are we looking at this through the lens of where is the evidence to support what people are saying we need? Because we know clinicians have very different views on things. They can be based on all sorts of things, not always on the most up-to-date research. So we have to have a way of fact checking that and ensure that we're not just being led by whoever shouts loudest.
I just on that much, and I think the criteria we've given people in terms of the sort of stock take is very clearly saying, don't just think about what you're doing today, but think about, first of all, why is this service even being delivered in hospital anyway? Secondly, does it have to be done face to face? Could it not be done digitally using some of the new technologies? So we're, and secondly, and thirdly, sorry, how do you work in a more joined up way with primary care colleagues to think about this model of care being a more integrated model of care, working with primary care? Now, that is quite cultural, as you just said. You know, we're having to help people see what could be possible, but we've also got to look at things like, we're asking people to highlight things like Royal College guideline, latest thinking from Royal Colleges, evidence-based sits behind some of these things. But you're absolutely right. Once we've collated all the information, especially, there'll be a process we'll need to go through with sort of a bit of testing to say, are people being ambitious enough? Are they being a bit over ambitious and thinking we're going to be some sort of specialist tertiary provider of something which frankly won't really be aligned to what we're trying to achieve? So I think you're right. We are putting in those challenges, but we'll also need to have a process where we can sort of test back, I think, clinicians on some of that.
Thank you.
Patsy?
Thanks, Chair. I recognising this is just a high level plan of the detail that's underneath, but there doesn't seem to me to be enough public engagement. The engagement is going on at the moment, and I'm sure there's a lot of that going on. But then there are decisions coming out of this phase that aren't then discussed with the public or through public engagement until the consultation on preferred options begin in March. So the public at the moment will only be getting very high level, you know, these are the issues we're facing, rather than these are the potential problems. And we don't want any of this to be a surprise, do we? Because we absolutely don't want placards and everything else that we frequently see. So I just think that there's got to be a space for more in-depth public consultation, almost ongoing through every phase of this, so it doesn't come as a surprise in March.
Linda?
Yeah, so I agree, and I think I just think we just need to be careful. What I don't want to do is go out to the public with some, to let them sort of vote on a range. We sort of need to avoid, we need to make sure that we're taking account of the public's views through our forums in a way that informs, it's like more like the co-creation than it is the sort of check and balance. Ultimately, we have to do a check and balance through consultation, but yeah, it's getting that balance, isn't it, between giving, because what we're trying to avoid, Patsy, is a process that happened before, whereby the outcome was determined essentially by a vote.
Mm-hmm.
And we need to be much more kind of data driven and sort of own the assessment. But I totally agree that it is about how we keep that ongoing conversation about what might happen and what the pros and cons of certain things might be, and sort of balancing that off with due diligence around the data as well.
Yeah.
Yeah.
I understand that, and absolutely the coming down to a vote is not the answer, but you almost need to get the public into a position, or our population into a position of saying this service is not sustainable in the way we're currently delivering it, so they're much more open to the consultation then when it comes out.
Well, it was interesting, wasn't it, that we had a session at our leadership, our community leaders group a few weeks ago, and actually one of the feedback we had from a gentleman there was, you know, to be honest, they said if there's some clinical reasons why you need to move things, we'd rather you just said, and we're honest that was the reason why, and so we are starting to test some of these principles already. We also, I think the other key players in this are elected members as well. So we had a bit of a conversation last week with one of the MSs, and they were saying to us, look, I accept, you know, what's said and what's reality can sometimes differ, but what was said was, if there is a clinical evidence base behind changing services and moving services, as long as I can understand that and articulate that to my constituents, then it's not my position to tell you that that's not an appropriate thing to do. So I think we are having those conversations at the moment, but at the moment it's quite high level of principles rather than, you know, we think this service here is unsafe and we're going to need to move that from here to there, or we're going to have to consolidate this service from A to B. And
that's why we put it in the August to December bracket, not the January. I think we're trying to protect January to February for us to go, this is where it's looking, and work with our staff around that. Because that's why this August, December, what the sort of conversations Paul's just discussed are so important to inform us.
Simon and then Mel.
Yeah. Thanks, Chair. I think what we can probably do a bit better, Patsy, is this isn't just about setting up, you know, road shows to engage people between now and December. It's about using those existing platforms and those forums that we've got, you know, through the RPB and PSB and all those kind of ongoing conversations, including things like the Leaders Forum as well, to have these conversations and just start talking about the need for change, but without talking about it in terms of moving service X to a different place as well. The important thing there will be having those conversations in a consistent way, so that the outputs from that is we can actually use that, we can count it, and it can be kind of quantitative and qualitative as well. So I think it's probably something we need to kind of work up a little bit more detail between in the next couple of weeks.
I think I totally agree with what you said, Patsy, and obviously I acknowledge what Linda just said, but I think a subtle way of us doing it, we're having the conversation that we're having about this report, and I would much prefer us to be having this conversation in a community setting, so at least we can acknowledge from what I'm getting at is, instead of having these boards, the board leaders here, we start getting back out into the community. So when we're having our conversations about all the changes that we are undergoing, we can legitimately say we're having these conversations within the community. So some of it, whether it be the Getting Aid Foundation, all the places we know we do it, people can sit in if they want for this particular issue, and there. So we must address not all the community, because I agree, Linda, it shouldn't be a board. When we had the South Wales programme years ago, it became messy. people don't understand it. But what we can do is start to influence the influencers and give them the information so they can start having their conversation with the people that they represent in the communities. But it ain't going to happen when we're all sitting in this room here in the hub down the road.
Mel, just give you assurance. I've set Gareth a task for the next 12 months. So if we're looking at 2024, we have 6 public board meetings and we have 6 board development sessions. I would like half of our board development sessions and half of our public board meetings to be held away from this building.
Well, I can also.
So what I'm going to do is some of that I thought would be on our hop. So we could do our board development sessions, for example, on our 3 main hospital sites, 1 on each, and then the 3 public board meetings away from this building, again using those community facilities and contexts, because I think that board visibility, getting out, talking to people, meeting with people is really important. We're seeing it in the work that's been done through the chief exec and others in developing the CTM 2030 leaders group. You know, the connection with our third sector and voluntary organisations in our communities, I think, has been really quite something to see. And that does provide a benefit, not just benefit for us, but benefit for them as well, because that working relationship is important in helping them to do what they do in our local communities. And I think if you look at the nature of our communities, we have a lot of organisations with significant reach. And I think the more we are out talking to people and working with them, the better.
That'd be challenging, but I mean, I'm sure Dilys would say the same. Any contacts that we've got for venues, please, God.
Yeah, well,
just give us a call.
Thanks. Dilys.
I'd just like to agree with you on the work we're doing on the leadership forum. I attend as many as I can, and it's really good to see my counterparts from the third sector being involved in these discussions and giving you their very frank views, which are very useful. And as you say, they're the people who are meeting the people out there in the community. So it's really important that we are involved with that.
Thanks for this. Jim.
I think I was just going to throw my own challenge with it. Questions based on what matters to people, what concerns them, what are the issues that concern them, but being open and giving people the opportunity to tell us what they think and what they feel will often lead them down the direction that Matthew was saying, where they steer themselves in a position, this is what we need, based on the evidence that's going to emerge from this. I think this process, as outlined, is very good. We shouldn't beat ourselves up about it. There's a lot to do with it, but this is a good base to start from.
Thank you. Any further comments or questions to Linda on the development of the clinical services? No? Okay, thank you very much. We just note the report. Moving on to item 7.2, we've covered partnership working, and I suppose in a sense, the various committee reports are before the board for noting. So I don't think there's anything specific in addition that we need to discuss there on partnership working. So item 7.2.1, the Regional Capital Board, the capital plan is before us this afternoon, and I'll ask Linda just to present the report for approval. Thank you.
Yeah, so this is where I've added single-handedly about 500 pages in this.
Yes, thank you. Can I just say, I've already said to the chief exec and to our new board secretary that maybe I should start applying a principle of 10%, 20% or 30% for people, because having reached was it 1,029, we've gone up from last month. Yes, exactly.
With my defence, some of it is particularly format. So let me just talk about the capital plan at a high level, because you may have some questions, but let's just paint the picture. Obviously, Welsh Government has changed its definitions of the capital allocations into the RPB. The reason it's really important is, well, it is important anyway, but it's also, remember, there's twice as much capital goes into the RPB as comes into the health board now, in terms of routine allocation. So, we've all got an interest in how this is spent for the good of the population. And I think, we definitely, the RPB did the right thing in commissioning a 10-year plan. It meant working with an external agency. And this is the product of that. So it's a point in time, it has been submitted. And it, I think, provides a useful background in terms of the analysis of, our start point with some of our facilities, the needs of our population into the future, and frankly, some quite scary numbers around the gap. Lisa's here, she oversees the children's agenda, big gaps in children's accommodation, big gaps in older people's facilities in terms of what we need going forward. So I would say that the RPB is now at the point of starting to really think about that and think about how we do then construct a 10-year plan. You'll see from the planning from the budget plans that they're relatively, the money's relatively allocated for this year and next. But then, you know, it starts to be a little less clear, which is a good thing, because I think we do need to stop and think strategically about priorities. There are some risks articulating here around workforce. I think one of the biggest risks is essentially around the affordability of the units and the revenue consequences. And, you know, quite a lot of what we're going to be doing is looking to our local authority colleagues who, to a large extent, are the ones with the duty to provide the services that are cited for most of these care groups. And, you know, obviously their ability to afford that capacity, you know, requires us to work quite closely and to be cognizant of that, but also to, you know, we also know that if that money's not spent, then the health board ends up picking it up. So, you know, we've all got an interest there. I think the other thing to say is that the allocations that are planned for the next couple of years, you know, anybody that's been involved in a capital programme, you know, it takes a long time to bring things to the market and then to discharge them. And at this point in time, it's actually proving quite hard to spend some of the, you know, to actually fulfil some of those capital schemes. Sunnyside is a really important one, which we're still stumbling to try and find an alternative builder to complete that scheme. So there's a few risks in there, and actually that's, I think what's a shame in that is that really we probably do need to have a few big schemes, but because of the difficulty of getting those off the ground, we end up spending the money on lots of little things, and those obviously have mixed outcome. There was one other thing I was going to say. Yes, the other thing I was going to say is that, and if there's any questions about any children's activities, I'm going to just warn you, Lisa. There's a whole section, a whole allocation around integrated care hubs, into the ICF, and the idea of developing integrated care hubs. And again, we're trying to be quite smart about that. And instead of building lots of small things that might not give us the value, obviously my steg is a really important priority for us. We've already got Keir Hardy in Merthyr. We probably need to look at, and as I say, if we get Sunnyside off, you know, finally off the ground in Bridgend, I think as a health board and with our colleagues, we probably need to prioritise just one or two areas in our CT that could be better. There's one area where there's a need for a new GP practice, so that's the obvious route there. So we're trying to be smart about that. I know there's a lot of information here, though, Chair, and I think, you know, we're presenting this at a point in time. This has been this assessment and these gaps have been put into this report and submitted to Welsh Government by way of assurance that we're doing the planning. But, you know, I bring it here, you know, noting there's still a lot more to do in terms of detailed plans for future years.
Thanks, Linda. Very much appreciated. And any questions to Linda on the plan? I know a lot of detailed work has gone into this, and you know, delivery is absolutely key. But can I say I'm conscious that colleagues do spend a lot of time engaging and supporting a range of different partnership environments beyond this work, and obviously the RPB is important for us as an organisation. So yeah, thanks to colleagues for the amount of that addition, and that is additional work. It's additional work on top of what has been done here within the organisation. But that partnership work is important because there is a shared agenda. And Linda, I think I did ask whether we could present the clinical services of the ambition of the clinical services plan to the next RPB meeting, which I think is in October the 26th or something, I think. But again, a good opportunity to engage colleagues from across different sectors about the ambition that we have as an organisation. Okay, if there are no other questions, can I ask if colleagues are happy to approve the plan? Yep, thank you very much indeed. Okay, moving on to item 7.3, the annual carbon plan. Again, back to Linda to present the report. The report just for noting, but Linda, over to you. Thank you.
Yeah, and apologies to our colleagues on PHP, where the timing just didn't allow us to go there first because there was something to submit. We had to bring this here. Again, I'm not going to drag you through the whole report. I mean, I'm going to just focus now on the numbers in the summary in cover paper. So page 346 essentially, and the next one. The headline, as you can see, and this is a report on the decarbonisation element of our green agenda. We've also got a whole waste reduction agenda, but that's not what this is. This is about our duty to report our carbon output. It's a sort of kind of fast-moving world in terms of how things are measured and what's measured. So it's quite complicated. That's why I think that the table that straddles pages 2 and 3 is really helpful. As a rule, our carbon output is coming down across all of our activities. It's just that we're measuring more. So, but that's a good thing too. So it's great that, with the investments that we've made in the what's it called, the power plant thing, and we've got quite a lot of sun panels on the roofs. We've got, more and more investment going in where we can in terms of low carbon fixtures and fittings. However, the rate of decline is still not enough to achieve that 16% reduction by 2030. That is the hard target, and that's why in Board Assurance Framework, as you know, we've talked about this before, we do flag it as a red risk, and the barriers are essentially outside of our control. When you think about the proportion, I think something like 70% of our carbon output is linked to our procurement, and we're now counting things like journeys, and I think that's just staff journeys. We haven't started counting patient journeys. So if we started to count that, then we'd be even, and of course the baseline because the measuring is changing, our baseline keeps changing too. But I don't want to cloud the fact that actually it's a good story. We are reducing our carbon output as an organisation.
Thank you, Linda. Okay, so we've got the report in front of us. Any questions to Linda? Patty?
Yeah, I accept what you're saying, Linda, but this is sort of telling me that the improvements are due to reporting changes as opposed to a genuine reduction of carbon output. And because it's difficult to see, you can't really read the appendix because it's not transferred into admin control particularly well. It's actually difficult to see what we are doing here. If you just look at fleet and equipment, it looks like we're getting massively worse, but clearly there's a lot more being reported. And some things aren't improving as much as you would expect them to improve, but we can't tell. You can't see the wood for the trees.
And we feel, to be honest, we feel the same. And by the way, we're healthcare professionals. We're not carbon experts. So I think, and all of it. No, so I think it's. All I can say is that where we are measuring things consistently, we do see the results of our decarbonisation activities. But the fact that this is such a moving platform, I agree, makes it hard.
I think Patsy, the other thing, which I'm sure you picked this up as well through finance route as well, is some of the things we would like to be able to do. There is a constraint about the resource that's available to do it. So capital particularly is a challenge because there are many things that I think we know we could do more with if we had more capital resource behind us. And unfortunately, these are projects that aren't even when we've got sort of leaking roofs and things that are already just needing maintenance to keep the show on the road. Unfortunately, these things, whilst they're absolutely important, we need to be thinking about how we do it. And this isn't unique to us. This is a challenge across whole of the NHS in Wales. But there are things that we are doing which I think will start to make an improvement. So we're just about to sign off the link. There's going to be a single wire link to the RCT solar farm just up the road here, which will provide all the energy for the Northern Morgan site. Those sorts of things I think are going to start to see an impact. I think you're right to highlight it, and maybe perhaps press Gavin what we've been on that how we might be able to develop a bit more of a reporting mechanism for this, which is perhaps a bit more of a dashboard sort of style, perhaps that we can start to sort of draw out, because there's a lot of detail in this, and I'm not sure also whether we need to know the nth level detail of every single car emission, and then but there's something about highlighting sort of key metrics about energy consumption, fleet utilisation, staff miles, patient. Maybe we could think about it in a dashboard model, which would help understand where we are going up and where we are going down. And then that, I think that there's also a question about where there's fees and things like the risk register as well and things like that, because these are risks against our target ambitions as an organisation, aren't they, as well as the carbon requirements.
I mean, there are easy things to do that don't have a financial impact, like the lease car programme only being hybrid cars. I accept it can't all be electric cars at this stage, but you know, it could at least be hybrid, can't it?
And to be fair, some of these things are also not just directly within our own control. They are like sort of shared services procurement things. But you're right, we need to put those things on there and articulate how much of that is directly responsible by us, how much of it relies on someone else to make a decision which impacts us, and how much it's a partnership.
So, yeah, only that the PHP does actually receive the decarbonisation action plan, which if those of you that aren't on it won't have that that benefit. But if everybody wants to see that, we can share. Yeah.
Thank you. Can I ask colleagues to note the report? Thank you very much indeed. Item 8, the consent agenda. What I'm going to ask for those items that are for approval, and item 8.1.1 all the way down to 8.1.6 to approve as a block. Are you content to approve all in one go? Thank you very much. And those matters for noting 8.2.1 all the way down to 8.2.7. Again, just a note. Thank you very much. Okay, now there are two items of any other business. The first is just to place on record the fact that a number of weeks ago I received a letter from a number of our consultant colleagues at the Princess of Wales Hospital raising a number of challenges they thought the Health Board needed to respond to, particularly about the way in which we're able to deliver services on site in terms of our resourcing and capacity and workload, and other matters around culture and behaviours as well. So a really detailed letter. We're very grateful to the consultants for getting in touch with those concerns, because I've always said, you know, as a health board, it's good that we as an organisation seek to engage and work constructively with all of our staff teams, you know, as ambitiously and as enthusiastically as we can do. And I've seen that in the last 6 months, and I was really pleased to get the letter because it was an opportunity for us to work through some of those challenges. So, as you know, I replied to that with a detailed response. On the back of that, yesterday we had a meeting with a number of our consultants at POW. Paul was there, Carolyn was there, Gethin, Sally and myself, and it was a very useful discussion with around 12 or 13 of our consultants talking about some of the challenges that they see on a day-to-day basis. And one of the outcomes of that discussion was that we've agreed that we will meet with them in the Princess of Wales Hospital around once a quarter. We will offer the same to our other two main hospital sites as well, because I'm very conscious that, you know, as we get now into winter planning, as we get into next year with the development of our clinical services plan, as we start to think about the shape of our services and how we deliver safe and effective care, I think this sort of engagement will be incredibly useful. So it was a very helpful meeting, and I'm pleased that they've raised the concerns with us. We've responded. There was a positive outcome to the meeting, and I was very pleased that a number of our colleagues in the room wanted to engage with us in addressing some of those immediate challenges, but also I could see a willingness on their part to engage in some of that longer term planning around the shape of our services as we develop our clinical services plan. So it was a really good session, Paul, I think.
Yeah, no, I mean, absolutely. And I think there were also some things which didn't come as a surprise, because I think there's some practical day-to-day things that people were frustrated about, which actually we can probably resolve relatively quickly. But I think it also highlighted, and we were able to sort of clarify for them, first of all, some of the concerns they had, particularly around things like leadership on the site, how that will be addressed through the next phase of the organisational change process. So we were able to say, well, we are responding to that, we've heard that, and we will respond to it. But also how important it is to have good leaders on the site and in specialties who can deal with day-to-day stuff that happens, because frankly, a lot of what was being raised should have been just being dealt with in this specialty. You know, somebody can't get a clinic room to run a clinic. Well, that doesn't need me or Gethin to sort out. That should be being sorted. But for whatever reason, they felt they're not able to get those sorts of things resolved locally, so they're having to escalate. And so part of this is also trying to set some expectations in the new structure about, we talked about, you know, being clear with expectations for people about what they can get sorted, and how do we build that culture of empowerment so actually people feel they can sort things out within their specialty. They don't sort of have the tendency to think, oh, well, I don't know, I can't get where I want to get to on that, so I'm just going to leapfrog about 3 link layers and got to speak to Paul or Gethin about it. So, but it was really helpful, and some really helpful feedback as well from some of our clinical directors who are now starting to take a more pan CTM approach, and perhaps a little bit of a challenge, dare I say, also back to some of the other clinicians to say, well, how much of this is the organisation's challenge to solve, and how much of it is your own personal challenge to solve, about go out and find the information. If you're not getting information or not having those conversations with the other colleagues in the other sites, where's your responsibility to go pick up the phone or go and arrange to meet with them and have that chat? So I think that was quite helpful as well. There was a bit of a sort of peer-to-peer challenge back into some of them as well, which I think is helpful. But you know, it's a really good meeting, and I think, you know, we've agreed we will write up the output, put it into some sort of plan of action that we will corporately support with, whether it's an OD support, whether it's digital support, whether it's estate practical support, and we will share that with them so they all know what we're planning to do as a consequence, who's doing what, so they know who the people to go to are, and also some timescales that we will then track through those quarterly review meetings.
Ian, you had a question?
Yeah, thanks, Chair. Just a quick point. It's great that we're doing this with groups of staff, but I think it was mentioned it was at consultant level. Should we be inviting other staff, nurse representatives and so on into these meetings as well?
So I did make that point yesterday to the consultants, because it was one of the things that came up when we had the letters from them. It was very specifically from a certain number of consultants. First thing to say, it wasn't all the consultants at POW, it was a specific number of consultants. And I did make the point yesterday that in our engagement, we need to be having these conversations as an MDT, that it's not just medics, it's all levels of medics, it's not just consultants, it's associate specialists, it's junior doctors, but it's also nursing staff, therapy staff, science staff, and other support staff as well. So
yeah.
The rationale for this conversation, Ian, came on the back of a very specific letter raised by those consultants. So I think there are some very specific senior medical staff things that are unique to them that we need to sort through this process. But in terms of the more general improvement work around POW, that clearly needs to be done as a all staff conversation and an all staff engagement process. So that's part of what we want to work through next, is how we broaden out to that wider staff group.
Yeah, thanks.
Thanks, Ian. The other additional business from me as chair is to say a very big thank you to a certain somebody who is attending his final board today as an independent member. Jim, it's been an absolute pleasure to work with you, as I found in the past 6 months, but I know you've been here as an independent member for the past 6 years, and I know how much the organisation has valued all of the effort that you have made, all of the work that you've undertaken on behalf of the board, the advice, the support, the guidance you've given as an independent member. And I know that today, this month now draws your term as an independent member to a close. I wanted to say a very big thank you to you on behalf of the board. We do have a little something afterwards by way of a celebration, because we're not celebrating your leaving, but celebrating all of the work that you've done in recognising the tremendous effort you've made as one of our independent members. So Jim, thank you very much indeed for everything you've done for us in the past 6 years, and I know we're going to miss you dreadfully, so thank you very much.
Yeah, can I absolutely. First of all, say everything that Jonathan said is true, because it was in his report earlier on, and our reports are factual and accurate. The other thing is, when you said that you announced that I was going, I saw the smiles light up across the table. So I think there will be a party. The issue is whether I get invited. But it's been a fantastic honour and a privilege to serve on the board, in the committees and in other work, and it's been wonderful to see the journey where we've moved along from reading reports where my initial response was so what, to where I've got data that's challenging, it's informative, and it enables us to have proper structured discussion about what matters, what needs to be done. Privilege of being able to go out and meet people from our communities, to go out and meet staff at all levels, to work with the IPFR panel, where behind the scenes you see the passion and the commitment that the clinicians and the medical teams put into their work to try to do the best for their patients, to get the best possible outcomes, often in very challenging circumstances. And a lot of that work is unseen and unrecognised. But the work that that panel does is brilliant, and it highlights the personalities that we have within the NHS that we should treasure and value, because they do an enormous service for us, for our communities, and I'd want to sort of put that on record. This is not a Pollyanna comment, because I also sit on the panels where persons haven't come up to the standards, and they're dealt with fairly and appropriately. And this idea of helping people to be at their best is evident in that work that I've seen as well. So that and the recruitment stuff has been fantastic, and I thank you all for the opportunity for doing that, and for the kind words.
Thank you. Thank you, Jim.
Legal advice is never free.
Stop talking now, because you're charging by the minute.
That was pro bono.
Thank you, Jim. Thank you very much indeed. Could I, before I bring the meeting to a close, could I also remind colleagues under 9.2, as we always continue to improve how the board performs and how we work, just to ask colleagues for any comments for improvement within the next 2 weeks. That'd be very useful. There's nothing to raise under item 10 in respect of in-committee sessions of the board. Just remind colleagues that the next meeting of the board held in public is on the 30th of November at 10 o'clock, and there is a board development session on Thursday the 19th of October here in this building. Rydw i'n dod y cyfarfod y bodd iecu i ben, hodyn y diolch y fawr sydd wedi yma yn ei gwylio y cyfarfod heddiw. I now bring the board meeting to a close, and would like to extend my thanks to all those who participated in the meeting and those who have observed our proceedings today. Thank you very much indeed. Yeah.